Assalamu alaikum, hello and welcome to the second day of the second NERD conference, the Neurological Rare Disease. Thank you all for joining today on Saturday, June 11th, 2022. We had a wonderful day yesterday. If you're joining us for the first time today, we had over 300 plus attendees join us from all over the globe, and it was wonderful to have your insights and questions and comments on a very interesting day. We hope that today will match or even exceed the education and discussions that were made yesterday. The NERD conference is accredited, and you will receive your CME certificate 7 days after this event has finished. You will see a questions and comments box in your auditorium. You can simply type any questions or comments for the moderator, and they will put it to the speakers during the panel discussions located throughout today. Today is a shorter day than yesterday. We have 5 sessions, and the moderators will go through that in a short while. If you have any technical or audio or video issues, you'll see a yellow man in the bottom of your corner. If you click on that, that will go straight to our IT support that can assist you with any issues that you may have. So thank you once again for joining us wherever you are in the world. We hope you have an interesting 3 hours, give or take. And I'll introduce one of the co-chairs. She is a real pioneer in the UAE in rare disease. Many of you that are in this country know her very well, Dr. June-11. She's a consultant and division chief pediatric neurologist at Tawam Hospital. She's in charge of the scientific program, and she will be co-chairing today with Dr. Shatila, consultant neurologist at SSMC. So I'd like to hand the floor to Dr. Jihan for the official opening of day 2 of the second NERD. The floor is yours.
Thank you so much, Jared. I would like to thank you and your team for the really great organization and flawless, platform that providing us. Welcome everybody. And as Jared said, today will be a slightly shorter day. And today we also have very interesting talks. If you see the agenda, so we have actually 4 speakers from here, from the UAE, and 1 international speaker. For the first session, to be honest, the whole session today is neurodegenerative conditions, genetic / metabolic diseases. However, more of a flavor of being really progressive from the onset for the first session, Huntington's disease, by Dr. Pierre from Yas Clinic, followed by metachromatic leukodystrophy by Dr. Valeria Calvi from Italy. Like I said yesterday, we actually selected the theme for this year quite similar to last year, which is rare diseases with potential treatment or research ongoing for potential treatment, diseases that can affect both children and adults, so that both pediatric and adult audience are welcomed in our talk, in our conference. And so after these talks, we will have a small panel discussion. Please type in your questions in the Q&A section, and we will address them at the end of these 2 talks. Following from that will be the second session, which is again neurodegenerative disorders with effect on many systems, so a multisystemic disorders session. However, we will be focused on the neurological really aspects of these conditions more or less. And myself and Ahmed will be giving 2 talks, and then we have a mystery disorder that Dr. Fatima Zahmi will be talking about. I would like to thank all our speakers They really all provide us with a lot of learning and education, even for us neurologists. I learned so much yesterday, even in diseases where I felt they were very close to my heart, and I'm hoping and looking forward to further learning from all the talks today. And I would like to also thank our sponsors. Without them, we couldn't really have this platform and also the selection of speakers they nominated and helping us with the scientific program and the topics. Of course, I would like to thank each and every one of you for sparing the time during your weekend to attend our scientific program. And again, big thanks to our behind the scene IT team. So with that, I will hand over to my colleague, friend, co-chair, Ahmad, who I would also like to thank him very much for involving me in this interesting series of meetings. And he will be introducing our first speaker.
Thank you very much, Dr. Jihan. Thank you for the kind introduction. As always, it's a great pleasure to work with you. I'd like to thank the audience for attending. Without your support, none of these events could happen. I'd like to thank all the speakers because, again, without your love to share your knowledge to our audience, to us, we would not grow as a physician or as a community. And then I'd like to thank the Gerard from Focus Golf, as well as his IT team, and all the sponsors as well. Today we have a very interesting speaker who's going to talk about a very interesting topic. Dr. Pierre Christkowiak has completed his neurology qualifications in 1997 in the University of Lille, France, then his PhD in 2003 in the University of Paris-Saclay. He's a professor of neurology since 2007 at the University of Picardie, Amiens, France. He held academic positions such as Vice President to the University Scientific Board and the Vice Dean of the Faculty of Medicine. He's also served as Medical Director of the Amiens University Hospital from 2015 to 2019. He joined the UAE in 2019, then YCKC in January 2022. He's published over 125 articles in international peer-reviewed journals, most of them in the field of Parkinson's disease and movement disorders. Today, Dr. Pierre is going to be talking to us about Huntington's disease, state-of-the-art and therapeutic perspective. Dr. Pierre, the virtual floor is yours for 30 minutes, sir.
Thank you, Dr. Ahmed. I'm going to share my screen. It's always difficult for me, actually, so give me a couple of minutes. Yes, this is. Do you see my screen now? Do you see my screen?
Yes, I see your screen and I hear you.
And you see me. Okay, fantastic.
Yep, I see you, hear you, and you are good to go.
Fantastic. Okay, thank you, Dr. Ahmed, and thank you, Dr. Jihan, for the kind invitation. You know, this is a topic very, very close to my heart, Huntington disease, since I started to deal with it now for 15 years or something like that, maybe 20 years in Europe. And my goal is definitely to launch the Huntington disease care in UAE and also in the Arab Gulf countries, actually. So I'm very, very happy to speak with you. I'm very, very happy that you invited me. So I'm going to talk about what is Huntington disease, but I'm sure that many of you know what it is, but mostly what we could do for Huntington disease in terms of therapeutic perspective. So, yes. So this is a summary of my talk. What is Huntington disease? Where are we in research? What are stem cells? Stem cells in HD, how to move forward, and I will conclude. So what is Huntington disease? Huntington disease is a rare progressive neurodegenerative disorder. It's very important to say that it's the most frequent rare disorder, actually. It gradually kills neurons, mostly striatum ones in the brain. This slowly deteriorates a person's physical and mental ability, and the disease is genetic, according to an autosomal dominant pattern with a full penetrance, which is really very, very important to say. There is no cure, and it's fatal in 15 to 25 years, and most cases of HD are diagnosed between the ages of 30 and 50. And there is also an early onset form of the disease called juvenile Huntington disease, and it affects people under age of 20. And just before this talk, we had a very short discussion with Dr. Jihan, who told me that she was following a juvenile patient with Huntington disease. So there are many symptoms of HD. Systemic, and HD is definitely, HD is a systemic disease with mostly a mix of cognitive impairment, movement disorders, and psychiatric troubles. But again, this is a systemic disease with also endocrine disorders and many, many, many things. So early signs include irritability, depression, poor coordination, trouble learning new information, and as the disease progresses and gets worse, you may experience jerking or twitching movements you cannot control. This is called chorea, and chorea definitely is a hallmark of Huntington disease, with also trouble walking, speaking, swallowing, and changes in personality, decline in thinking and reasoning abilities, significant weight loss. Okay, this is not only a neurological disorder, this is a systemic disorder. This is very, very important. So now actually in Huntington disease, we moved from the gene, CAG repeat expansion, more than 39, and then with many, many, many different mechanisms from neuroinflammation to reduced BDNF, and including mitochondrial dysfunction, you have a lot of median spiny neurons. Of course, the neurodegeneration, the degeneration do not include only medium spiny neurons. Actually, this is a general degeneration, but the cells which are the most affected by the disease are definitely the medium spiny neurons, which are located in the basal ganglia, caudate nucleus, and lenticular nucleus putamen. So where are we in research right now? So we have several options. Of course, symptomatic treatments to calm down the chorea or to calm down the behavior disturbances or something like that, but actually it's not really satisfying. So of course, we try to develop some disease-modifying treatment and cell therapy, knowing that cell therapy plus disease-modifying treatment is definitely the holy grail. At least in theory, because of course you understood that right now it does not exist. This is what we aim to develop, but right now it does not exist. So here you can see a diagram with the stem cell loss and the symptoms, cell loss in red and symptoms in blue. And of course, symptomatic therapy cannot modify the course of the disease. It calms down the symptoms, but if you try to administer a disease-modified treatment, you hope you're going to slow down the disease, like here. And of course, if you combine, if you give some cell therapy, you're going to do this here. So you're going to repair the brain, and it's good, of course, but after that, if you do not slow down the progression of the disease, it's going to progress again. So definitely a good combination is cell therapy to repair the brain, where you have a neuron loss, you put some new cells, and then you also have to slow down the disorder, slow down the production of huntingtin, mutant huntingtin, and finally you are here. So this is what we would like to do actually, but it's not that easy. So disease-modifying treatment. Okay, first of all, we aim to target neurodegeneration. We have many approaches to target neurodegeneration. For example, laquinimod or RP103. Okay, why not? What is more interesting is to target Huntington gene or formation of Huntington protein, either, for example, with interference RNA or with antisense oligonucleotide. This is really a very interesting strategy. Just we have to stop the production of the mutant Huntington protein, which is definitely the key point of the process. But we have also to repair the brain, and not only the brain, but mostly the brain, because this is a disorder which mostly affects the brain. This is called repair therapies. So repair therapies, actually, you have some growth factors like CTNF or GDNF, and you have also cell transplantation. And you want to do some cell transplantation in the caudate nucleus and also in the putamen, which definitely are the most important regions in terms of neurodegeneration loss. So it can be stem cells, but it can be also primary fetal striatal tissue. And it started with primary fetal striatal tissue, I'm going to tell you. So what is the rationale for repair therapies in HD? So the rationale is to restore striatal cell loss through implantation of dopamine-releasing cells to make synaptic connection. And here you have a very interesting picture of a transplantation of fetal cells on the right side of in this patient, in the caudate nucleus and also in the putamen. And finally, you can see that here there is a neuron activity that shows that you have established new synaptic connections again on the right side. And all this to restore neural circuitry and also to reverse extrastriatal retrograde degeneration, because actually, okay, there is a global brain degeneration, but more and more experts and there are more and more scientific evidences that to say that actually the global brain atrophy actually is a consequence of extrastriatal retrograde degeneration. And finally, what we want to do actually is to achieve a clinical improvement. So let's get started with fetal striatal tissue transplantation. Okay, we started with this now 10 or 15 years ago, and I'm going to talk about it. But now, as you can see in 2029 or in 2020, do fetal transplant studies continue to be justified in Huntington disease? Underlined, while we now have the possibility to administer the patient some stem cell therapy. So here you have a list of what has been done with fetal cell transplantation over time. So it started with Los Angeles series, and finally, I'm just going to quickly talk about the MIG HD trial because it involved 45 patients. It was the biggest trials so far, and finally, to say what, no clinical benefit. So this paper has been published in 2020, but actually, I was a baby neurologist when it started in Europe. I would say now 12 or 13 or 14 years ago. Not really a baby. And finally, here, as I told you, the study timeline is patients were transplanted between 2001 and 2013. Can you believe it? Okay, this kind of trial is just a nightmare, actually. So why was it a nightmare? Because of practical organizing difficulties of undertaking a transplant study with fetal cells. And for example, we had 90 grafts, but with 163 occasions on which surgery was cancelled due to inadequate, insufficient donor tissue. Honestly, I was a baby neurologist, or I was really a baby neurologist in France. It was definitely a nightmare to organize it. And also, it was also a nightmare because we have on her back the regulatory framework. So here you can see that in red, okay, the clinical trial started in 2002, practically. First patients were included in 2002. And finally, you can see in red the periods of times when the clinical trials has to be discontinued because of administrative and regulatory authorities orders, actually. So it was very, very difficult to organize practically. So it was a kind of disappointing, but it has shown the way. So the clinical improvement is related to enough functional donor cells. This is very important, to re-innervate the host tissue, to make synaptic connections, to restore neural circuitry. But the negative outcomes were too small or unhealthy graft with no fluorodopa binding in PET increase. Can you believe that in 82% of the graft patient, we didn't have any raised activity, raised metabolic activity on the PET? So it can be explained by the poor viability of transplanted cells, can be explained by lack of integration of the graft in the host tissue, donor tissue outside the optimal gestational window, poor vascularization of the graft, non-pervasive host environment, and also immune rejections. And here, honestly, we could not believe that, actually, that in this deemed privileged organ, which is the brain, we could have graft rejections with fetal transplantation. This is a paper we have published a couple of years ago. So definitely fetal striatal tissue transplantation has made it, now it's over, but it has shown the way to stem cell therapy. And here you can see that not only for Huntington disease, but also for Parkinson's disease, Alzheimer's disease, or amyotrophic lateral sclerosis, you can use some pluripotent stem cells, and you can get some mesenchymal stem cells or neural stem cells. What is interesting with neural stem cells, of course, is that you can repair the brain because it can induce some astrocytes, neurons, and oligodendrocytes. And you know that Huntington disease is not just only a neuron degeneration. And mesenchymal cells is also a very, very interesting option because it can repair the brain, but it can also induce the secretion of growth factors like BDNF or GDNF. So these two approaches are very, very interesting. So what are stem cells practically? So I'm going to give you very easy definitions by first of all, by the NIH. It's a process of creative living, functional tissues to repair, to replace tissue or organ function lost due to age, disease, damage, or congenital defects. And Dr. Chris Mason, who is a pioneer in stem cell, his definition is to replace or to regenerate human cells, tissue, or organs to restore or establish normal function. So I'm going to skip this one again because I'm a little bit late, sorry. So strategies for developing new ADHD therapies start with preclinical studies. And we have a handful of stem cells preclinical studies with human embryonic stem cells or with induced PSEC, or with adipose-derived stem cells, or with genetically modified stem cells. But again, this is just a handful of stem cells clinical studies. And as you know, to move from the preclinical studies to the clinical studies, there is a huge, huge gap. So just here a slide to explain the Holy Grail I've been talking about a couple of minutes ago. So definitely the Holy Grail is stem cell therapies to be combined with gene therapies. I mean, okay, you have to repair the brain where you can observe a neurodegeneration loss, but at the same time, you have to stop the production of the mutant huntingtin And definitely it can be done with gene therapies, like I told you about interference RNA therapies or antisense oligonucleotide therapies. So here, when you go to the websites of the US clinicaltrials.gov, you have only a handful of ongoing clinical trials, but nothing has been published so far. So actually, it's really in development. So here you have just five clinical trials on this clinicaltrials.gov site. Nothing else, nothing published right now. Now, what are the next steps for future clinical trials? Actually, first of all, we have to refine the clinical trials in improving what we want to do with preclinical studies. We increase knowledge about graft components, use information to enhance stem cells derived products, test in animals, improve surgical devices, understand more about alloimmunization. 2, better define clinical studies with newly designed protocol, new cell products, etc. So newly designed protocols, better patient selection, outcomes improvement, and digital measures is very, very important. So definitely we have to intervene much earlier. Earlier, it means intervene in pre-manifest stages, pre-symptomatic or prodromal. And we need to identify, of course, family members at risk. We need to use neuroimaging and biomarkers to detect pre-HD and early HD individuals. We need also to proceed to refinement and automation of outcomes measures to reduce bias. We need to use higher sensitivity measures of cognitive behavior and motor function. We need to use neuroimaging and biomarkers to monitor the disease progression in symptomatic patients. So we also need to develop new sources of stem cells. And here you can see again that we have the choice between, for example, mesenchymal stem cells or adipose stem cells or neural stem cells or striatal precursors. This is something very, very important. So regarding surgery progression, it's not trivial. To put some cells inside such a big target to repair the brain can seem easy to perform, but it's definitely not. So this kind of functional neurosurgery is definitely not trivial, and it needs a specific training. No, even if you get a neurosurgeon, an excellent neurosurgeon, he has to be trained to do that. It's not that easy. So this is very, very important to put the good cells in the good target, and you have to be sure that the cells are in the target, and it's not that easy. So of course you have to deal with the alloimmunization, and I've been talking about that a couple of minutes ago. And again, the brain is also not an organ like others, but you have also to take care of the risk of alloimmunization and you have to take the necessary caution to avoid that. So now, how to move forward in UAE? So first of all, here you can see this map. 54 million people in the Gulf Arab countries. So, and with a prevalence of Huntington disease that moves from 3 to 4 per 100,000 for the whole regions to here in this study to 21 per 100,000 regions. So patients are definitely very scattered, sorry. And so, and recently, until recently, I mean recently, in 2020, so 2 years ago, Ferdinando Squitieri suggested that the prevalence was similar to that of Europe in Oman, actually, with a prevalence of 7.36 per 100,000 patients. So actually, the problem is, where are the patients? So half of my UAE, KSA, and Kuwait colleagues told me, I have been here for a long time, but I only follow a handful of patients. And the other half say, I've never seen a HG patient in my life. So right now, just prior to this talk, I had a quick discussion with Dr. Ahmed Chatela. He told me he has a full a full family with Huntington disease, with many members affected. Honestly, okay, this is great. This is great because we need to detect where are these patients and why do not we find this patient. We have multiple potential reasons, actually. Misdiagnosis. I'm convinced that there is a huge misdiagnosis with Huntington disease. I'm completely convinced that there is a specific profile of HD in UAE, and especially with probably and possibly more juvenile forms of Huntington disease who could be cared as schizophrenic patient or other mental health disorders. But I'm convinced that the patients are here, and I'm not the only one to be convinced. Again, I just talked a couple of minutes ago about the Oman study, and definitely I'm convinced that the prevalence is similar to the usual prevalence in the other countries. So the patients can be followed only by general practitioners or other family medicine doctors. There is definitely a lack of knowledge of the disease and its genetic impact on families. There is a lack of knowledge of existing symptomatic treatment. There is a lack of knowledge of research progress in care and treatment. There is a lack of HD specialists. There is insufficient access to genetic testing. So, okay, we start almost from zero, but honestly, I think we need to move forward now, especially since now the game has changed. So where are the patients? Where are the gene carriers? Okay, can Malafi help find the patient? You know that Malafi is a kind of software that can interconnect all the healthcare facilities, and you can do some request with some ICD-10 specific coding. Okay, I can ask the DOH how many patients with Huntington disease we can find in UAE, at least the one who have been diagnosed. This is a first step, but the very, very interesting step is, can Emirati Genome Program help find the gene carriers? I mean, gene carriers is not only the patient, it's also the pre-manifest. And I'm very, very happy to talk about Dr. Fatima Al-Kahabi, my boss, who is in charge of the ADSCC center, also the YCKC center, but she's also responsible for the Emirati Genome Program. So I hope that we can do some requests on the 250,000 full genome sequencing stocked right now in the G42 lab in Abu Dhabi to try really to understand exactly how many patients and how many gene carriers we can rely on, and we can detect for a better diagnosis, of course, but also for a better care, and also possibly to prevent the onset of the disease. This is not a dream. I think it can be achieved, not right now, but in a couple of years later on. So DMT such as Huntington lowering therapies
3 minutes remaining, Dr.
prevent the disease for developing. I'm talking about the interference RNA or treatment or oligonucleotide and antisense oligonucleotides. But as you possibly know, actually, during the phase 2 studies with antisense oligonucleotides, we had very, very amazing preliminary results that pushed us to develop a phase 3 study, and finally, after the phase 3 study, for definitely an unexpected reason and an understandable reason, it was a double setback for ASO. We still do not understand what is going on, why this phase 2 studies results was so promising and why it failed with the phase 3 studies. So therefore, right now, stem cell therapy is the only approach currently focused on structural and functional restoration, and is the most immediate promising option, provided we find the patients in UAE. So please, if you have some Huntington disease patient in UAE or even in the other Arab Gulf countries, I would love to discuss with them to do some genetic testing, to do some research. So you can contact me at any time. Thank you so much for your attention.
Thank you, Dr. Pierre, for the very interesting and up-to-date review on Huntington's disease. And as you said, these patients do exist. We just need to keep our eyes open, and we got to think about it. So with that, we will, right now we'll have we'll have another presentation, then we'll open up the floor to panel discussion. So hopefully you can stay with us after the next presentation for the panel discussion.
Dr. Valeria, hello.
Hello, good afternoon to all of you.
Welcome aboard. Thank you for joining us. So we will now move to the next talk, which will be given to us by Dr. Valeria Calvi from Milan, Italy. Dr. Valeria is a hematologist at San Raffaele Hospital in Italy, Milan, with clinical experience and research in stem cell transplant. She's currently working as a pediatric immunohematologist in the San Raffaele Hospital, and her clinical activities include looking after patients, pediatric patients mainly, with hematological and immunological diseases, including diagnosis and management. More importantly, I guess her currently clinical researches are addressing many disorders, including immunodeficiency, hemoglobinopathies, and metabolic disorders, with extensive research into therapy with hematopoietic stem cell and gene therapy. Currently, she's focused on metachromatic leukodystrophy research and treatment with this form of therapy. Which is, there is a lot of novel things into this. So today she will be talking to us about this topic, metachromatic leukodystrophy, early detection, signs and symptoms, experience from patients' MLD clinical trials. Dr. Valeria Calvi, the floor is yours.
Thank you very much. Thank you for the nice introduction, and thank you for the invitation. So I'm very glad to be here and have the opportunity to present also our data. Just a moment that I try to share my screen. Okay, can you see my slides?
Yes. Perfect.
Perfect.
Yeah.
Thank you.
Thank you so much.
Okay, so I'm trying to describe you. I will give you a brief overview of the disease of metachromatic leukodystrophy, and we shall discuss a bit about the treatment option and about the results with hematopoietic stem cell gene therapy. So here are my disclosures. As probably already said, I work in San Raffaele Teleton Institute, and our mission and the aim of our research is basically try to find a novel therapeutic option for rare genetic diseases. And so this is my first slide, and the aim of this picture is try to point out since the start, so from the beginning of our discussion, how is important the early diagnosis and how much can make the difference. In fact, here we can see two siblings, one brother and one sister. So Joe was diagnosed for metachromatic leukodystrophy following the onset of symptoms in his sister, and he could access treatment, and in particular gene therapy, and is now 7 years after transplant still free from disease, while his sister could not access any treatment, so is just on palliation and severely disabled. So just I want to say to keep in our mind early detection, and the fact also that behind up to now, even now that some treatment options are available, behind every success, so every patient that could really benefit from treatment, there is always a sibling or a familiar case they couldn't access treatment, and we need to find a way to change this, and this probably can be early diagnosis and possibly neonatal screening. We will see at the end. So as you know probably better than me that I'm a hematologist by training. So metachromatic leukodystrophy is an autosomal recessive genetic disease caused by a biallelic mutation in RCA gene, and the lack of its corresponding enzyme cause sulfatides accumulation both in central and peripheral nervous system. Classically, we can recognize three main subtypes of MLD, of metachromatic leukodystrophy, classified by the age of onset. So we have the late infantile variants with onset, with symptoms onset before 30 months of age, the juvenile variants that is usually broken into two variants. So the early juvenile with onset before 7 years of age, and the late juvenile variant with onset with age above 7 years. And then we have adults onset. As in other lysosomal storage disorders, the prognosis may vary and may depend with the severity of mutation and age of onset. In fact, have been described that the early variants have a more aggressive clinical course, and particularly the late infantile variant and the early juvenile variants are characterized by a very rapid motor and cognitive function decline, and severe disability that is pictured in this part of the slide. So the onset of GMFC 5, so a severe disability with loss of locomotion and capability of sitting with support and control is reached few years after the onset of disease. So we can see here that the early onset variants, so in particularly the early juvenile and the late infantile, have a trend of progression quite similar and different from the later onset form. So in this disease, disabling symptoms and eventually death is reached a few years after the diagnosis and after the symptom onset. So the pathophysiology of metachromatic leukodystrophy is common across all the variants. So as we said, we are used to know that the phase of the disease progression, so where there is the decline of all the motor and cognitive function, and the slope of this phase depends on the disease subtype, so the slope and the duration. But I think it's important also to focus our attention that the initial phase of the disease, so in particular the phase of normal development that is usually followed by a plateau phase or stagnation where initial subtle signs of the disease could be recognized. Also, this part changes among the different subtypes, and particularly in the very early onset variants, so late infantile and early juvenile, this phase could be very brief and short. And this means that the window where we can identify early the signs, so where we can identify the patient that could really can benefit from treatment, that could be very narrow. The demyelinization and the neurodegeneration that results from the sulfatides accumulation in MLD gives various spectra of symptoms, but they all give progressive motor and cognitive impairment and eventually very disabling symptoms and death. So we can see progressive loss of motor function with loss of walking, standing, sitting, and head control, loss of fine motor skills, loss of the speech and speaking capability, vision, hearing, and other sense. In the very late stages, of course, we have symptoms related by the severe spasticity, pain, seizures, dysphagia, and eventually the severe disability brings to death. If we focus our attention on the early onset variants that, as we said at the beginning, are the one more severe in the clinical course, we can see how for the late infantile variants, usually the presenting symptoms are related to motor symptoms, so hypotonia, weakness, frequent falls, gait impairment in general, and less frequently with the cognitive decline, which is more common for the later onset forms. Is worth to point out that for the late infantile variants that have a very brief story of normal development, initial signs of disease could be even just missing of normal developmental milestones or a kind of stagnation in the normal development. Even if we see the symptoms that are reported from the caregiver, we see a kind of, we confirm that the initial symptoms reported for the late infantile are more of motor nature compared with the early juvenile. But also in the early juvenile, usually the common symptom is gait impairment, but sometimes it could be also some change in the behavioral and in particular some decline in the school performances. After initial symptoms that, as we said, sometimes can be subtle and somehow confusing, but after initial symptoms, usually the patient requires a confirmatory diagnosis, and the confirmation of diagnosis is done basically with biochemical testing, so ARSA enzyme results low in blood, and we test the urinary sulfatides that are actually elevated. That is sign of accumulation. The suspect is confirmed by the genetic test that must confirm the presence of the allelic mutation in the gene. The brain MRI, of course, sometimes can give depending on the phase when the diagnosis is made, but when is performed in a clear symptomatic status, gives a pattern of demyelization that is quite typical and suggestive of metachromatic leukodystrophy. Although we must consider that very, very early in the clinical course, and particularly in the pre-symptomatic phase, the brain MRI may also be normal. Classically, the treatment has been supportive and based on palliation of symptoms. The difficulty in developing a definitive curative treatment strategies are basically consist in in the need in MLD to cross the blood-brain barrier. So the difficulties how to effectively target the central nervous system, and up to now is where the classical strategy, for example, of enzyme replacement therapy that are employed in several lysosomal storage disorders here in MLD are so far failed. Allogeneic stem cell transplant that also is a treatment option that gives good results in other lysosomal storage diseases, has the aim to deliver systemically a functional enzyme from a donor cell. And unfortunately, in MLD has shown limited results. So while we demonstrated slowing in the disease progression in the later onset variants, as we have not seen good results in the early onset variants. So just to reason around this, what we learned also from other inborn error of metabolism and from the standard bone marrow transplant experience is generally that the early is the intervention, better is the results. So here we can see some data, for example, I think these were from MPS 1, and we see how the treatment outcome depends from the age of onset. What we saw in MLD. Of course, we need to say that the experience in allogenic transplant, the published data, sometimes the series are a bit limited and is a bit difficult to draft a final conclusion, but still we can see that in the late infantile variant, both the cognitive and the motor outcome, both in symptomatic and asymptomatic patient, is very different from the normal population. So the benefit is very limited. We could see here in the juvenile subset that we have some patients that still can have at least delayed of symptoms and good cognitive and motor outcome, and these are mainly in the pre-symptomatic patients. So even from this limited data, we can say that the pre-symptomatic have a better outcome. But from other experience, we can still see that many patients here, there are more than 1/3 of the patients that still after transplant reached a severe disabled status, so a GMFC of between 4 and 6. And these disabling symptoms are reached even in patients that were still treated pre-symptomatic. So it is clearly a therapeutic option that required, let's say, improvement. And from here was, from this observation was the idea, as was done also in other fields, like in other genetic diseases, was to explore the possibility of hematopoietic stem cell gene therapy. Hematopoietic stem cell gene therapy is an autologous transplant of CD34 selected cells engineered with a lentiviral vector encoding for HERSA gene. So it means that is an autologous transplant of hematopoietic derived cells, of stem cells of the bone marrow. These cells are autologous, so are collected from the patient, either from bone marrow directly or for mobilized peripheral blood, and are infused after a conditioning like in a standard autologous transplant. So here clearly there are two potential advantages over the standard bone marrow transplant, and this one, that this is an autologous procedure, so there are no risks of of rejections and other complications like GVHD that still give a certain account for a certain grade of mortality and morbidity after the standard bone marrow transplant. And two, that with this procedure, we are able probably to achieve a higher expression of ARSA enzyme. So the rationale is that the gene-modified cells are able to migrate to the central nervous system, where they can replace the resident microglial cells and express as a gene-corrected cells can express a functional enzyme that can be released and, of course, contribute to detoxify the environment and also eventually probably cross-correct the surrounding cells. So we started to develop in the clinical field this strategy almost 20 years ago. And the first clinical trials started more than 10 years ago. And eventually we have been able to collect the data of the long-term outcome of the patients that were treated with this strategy. And these data were recently published and allowed eventually the EMA approval of this strategy as a real medicinal product, so as say an available treatment option, so no more experimental. And the final indication, and now we will go briefly through the data, is that this option, so the gene therapy, is indicated in early onset variants. That's what was because we designed this strategy for the more severe treatment variants, disease variants. And in the so for the early onset variants, so means late infantile and early juvenile forms, and in particularly pre-symptomatic late infantile and early symptomatic early juvenile. So late infantile only pre-symptomatic, and early juvenile either pre-symptomatic or considered early symptomatic. Okay. So now I will go through the data briefly. So eligible for the trial were the early symptomatic, were early onset patients, and particularly pre-symptomatic late infantile and either pre-symptomatic or early symptomatic early juvenile. And the outcome of this patient was compared to the outcome in terms of cognitive and motor outcome of a cohort of natural history patients that were prospectively followed at our institute. These patients, in the cohort of this patient are included also several siblings of the treated patients. In all patients that have been treated with hematopoietic stem cell gene therapy, both in late infantile and early juvenile, we managed to achieve a reconstitution of ARS activity to normal or supranormal level, and this was maintained very stable through the whole follow-up and even in the long term. So now I think that the patient with the longest follow-up has almost 12 years of follow-up and still maintains stable levels. In terms of clinical outcome, so we measured motor outcome in terms of gross motor function measure, and here we can see that in the late infantile patients, we measured at 2 years a big difference in terms of GMF. And the difference was of course significant, and the striking difference with the natural history, 80% almost versus 8, and this was maintained even at 3 years. In the early juvenile patients are included also early symptomatic patients. Still, we had a good difference that far exceeded the 10% that was actually the main primary endpoint, although was not significant at 2 years, but it became significant at 3 years. This demonstrating how the strategy is able to lower significantly the disease progression compared to the natural history that here we can see in orange. In terms of achievement of the later stages of the disease, so means in particularly we defined the severe motor impairment-free survival, the time to reach a GMFC of 5 or higher. We can see how is the difference between the treated patients and the untreated patient for the late infantile, and for the early infantile we can confirm how the patients that were treated pre-symptomatic had a better outcome compared to the natural history than those that were treated even in early symptomatic status. So here we confirm the previous impression and what we learned also in other lysosomal storage disease, still that the earlier is better, at least we think. Despite various degree of motor deterioration that still was observed in the early juvenile subset, we can see here that in terms of motor cognitive outcome, the majority of the early juvenile patients, both symptomatic and early symptomatic, still maintained a good cognitive outcome within normal limits, even in the long term, with some exceptions that were considered failure to treatment, and they were both patients that were treated really symptomatic at the time of disease. The good outcome was also for the late infantile patients. The two big exceptions were these two patients. So one was a patient that was actually starting to show initial signs of disease at the time of treatment, so was pre-symptomatic in the screening phase, but then through the baseline, then the treatment started to show some sign of disease. And this again suggesting that the window of intervention for this very early onset variants is really narrow. So we need really to try to target this patient before they approach the expected time of age of onset. This also was a patient that actually had a good development up until a certain stage and then started to decline. So we had the kind of delayed disease onset. And this was a late infantile patient that was treated at 18 months of age, was pre-symptomatic, but was really close to the expected age of onset. Here, I really want to give you an idea of what, with some videos, what we seeing as a spectra of outcome. Here we see our patient number 1, late infantile, and is now almost 10 years after transplant, and he can walk with support, And this situation, as pictured by this graph, is very stable over these 10-12 years, while the affected sibling died already now since some, I think, years, and had a very classical course, disease course as a true late infantile. His cognitive function is normal and goes to school regularly. Here is our patient number 2, and has a motor outcome that is completely normal. So GMFC 0 throughout the follow-up. Even this 1 hour has reached, I think, 10 years of follow-up, and this is striking difference with the affected, with the affected sibling. And here we have this also was a late infantile, while this third one is an early juvenile patient, still with a normal, it was the one of the picture at the beginning, normal function, difference from his sister. This outcome is also demonstrated by these images in terms of improvement in the demyelinization process. Here we can see pictures of brain MRI of a late infantile patients, pre-GT. Here you can see how pre-GT at 7 months of age in a pre-symptomatic late infantile, really the signs of MLD are really subtle. Sometimes we receive images that are reported as normal because really the signs could be really very subtle. Through the follow-up, we can see here how we can start to see some part of the myelinization, but they remain really stable throughout the follow-up, in striking difference with the untreated patients, the affected sibling, basically at the same age. Here the picture of an early juvenile patient that is actually the one of the picture of the beginning and the one of the video. You see that despite in the pre-symptomatic phase, here we have already some signs of MLD in the brain MRI picture, with the myelinization and impairment in the white matter, and these signs clearly improved through the follow-up after treatment, still in difference with the affected sister. The safety of this strategy was good. So we lost 3 patients. 2 patients died due to disease progression, actually, and they were all patients, early juvenile patients that were treated.
2 minutes remaining.
Yes, that were treated before while symptomatic. We saw only some adverse events that were related to conditioning. So overall, we achieved good results. And as I said at the beginning, these results prompted to EMA approval of this strategy. So how to expand the access of this promising treatment to the patients was to try to identify treatment centers across Europe now that this treatment is available. And so what is remaining is, I think, to try to demonstrate even in later onset form, where we still see the treatment options are still limited, if we can demonstrate if this kind of strategy could also be employed. And our question mark at the beginning, given the rapid progression of the disease, how can we do early diagnosis, probably through implementation of humor screening, but that, as we know, would also pose some challenges considering the different genotypes that we can encounter in these programs, and considering also that a follow-up algorithm is not yet in place for MLD, but still there are some plans and some programs of newborn screening have already been launched, and hopefully we can see how the early diagnosis could also improve could also improve the results for this kind of strategy. Then, of course, there is the matter of how to access to this treatment, and also the economic part related to that of course doesn't make it accessible to all. I want to thank all our group and of course the TGET lab and all our group, and of course I'm here available to answer to your question, and thank you for your attention.
Thank you very, very much, Dr. Valeria Calvi. Actually, a great talk coming from an immunologist, a hematologist, but honestly, you addressed also the neurological and imaging, probably better than us neurologists. Thank you so much. We do have time for 1 or 2 questions. I think the questions we have for you probably about newborn screening programs for MLD. Is that something that is happening, about to happen? You think it should happen, especially that we need to treat pre-symptomatically, and once the disease is symptomatic, the outcome might be poor?
Yes, as I tried to put an hint in the last part of the presentation. So there are good data on how to identify through measurement of sulfatides by tandem mass spectroscopy in DBS, and so how to detect affected patients. So these data that were mainly published by my colleague Gelb prompted different lab to employ the same technique and try to launch regional newborn screening. So one is for sure already launched in New York, and one I think in Germany. So I think it's important because, as we said earlier, is better, but still we need to be ready to face some challenges because, of course, there is no complete correspondence between the MLD type and the genotype, and still gene therapy is true, is available, but is available in not all the variants, and so decide how to who intervene, when to intervene. Still, we need to be ready to handle some issues, but I think is good to start.
Absolutely. And do you have a registry, or do you have an idea of how common the disease in your population? I guess it's probably higher here in the Middle East, given the consanguinity, but we read these, prevalence rates of 140,000 or 100,000, but in real epidemiologic studies on this anywhere?
The epidemiological studies, we estimated that at least you should be few cases, 1 or 2 cases over 100,000, I think. But even epidemiology will be more clear, I think, with the newborn screening population, because we still will feel that we miss many diagnoses.
Absolutely.
And I think it would be the same also to you. Yes. In Europe, we tried to, of course, being a rare disease, we tried to, let's say, network as expert centers, especially more, of course, the neurologists and neurometabology, to try to have a project in databases and initiatives to collect data, both on natural history and treatment and treated patients. I think collect in a consistent way in a network, in a good network, would really help to give more light on really the epidemiology also, and the natural history, and really also the treatment outcome, because even the outcome of, for example, allogeneic bone marrow transplant are scattered. So we are feeling in Europe that we need to make an effort to put all the efforts together, and probably would be good also with the other countries, would be advised.
Thank you.
Thank you. And I can ask some questions. First of all, there's a lot of comments thanking both the speakers for the excellent presentation. So thank you both for actually taking time today to talk to us. Here's a question to Dr. Pierre. So interesting to hear about Huntington's. How can we improve public health screening in the UAE? Public health screening, is it just one of those things that you got to have a high index of suspicion, or should we be doing preemptive screening on people? Well, how would you approach this?
Okay, we have actually two different approaches, as I said in my talk. One approach is definitely to use a welfare system and to try to detect Huntington disease patient with the ICD-10 code for Huntington disease. This is the first approach. And definitely there is a real will for the DOH, at least in the Abu Dhabi Emirate, to deal with rare disorders. So this is one approach. The second approach is definitely to use I would call that the inverse epidemiological study, inverse because, okay, let's start not with clinical data, let's start with genetical data. So the possibility of screening Huntington disease gene within the full set of whole sequenced genome is definitely another approach.
Dr. Pierre, am I confused? I thought because Huntington is caused by trinucleotide repeat, and my understanding is whole exome and even whole genome might easily miss these, right? I mean, the trinucleotide repeat, similar to, for example, myotonic dystrophy in children, you have to ask for that specific CAG repeat or CTG because a whole exome or whole genome will miss that. Am I right?
Yes, of course. This is a big word of the CAG repeat disease. Yes, you're right.
So I mean, if you talked about the Emirati genomic program or the way we screen, I mean, this is an area where even many people will be, usually investigated by a chromosomal microarray when you have a disease. I mean, not Huntington, but you're suspecting a genetic disease, chromosomal microarray, then proceeding to whole exome, then proceeding to whole genome. And I have seen many trinucleotide repeat disorders being missed this way. So unless you do the specific testing for that, so is that being addressed somewhere?
Yes, you're completely right, actually. Again, we don't, regarding only Huntington disease patients, I do not see Huntington disease patients in this country. My colleagues tell me that they don't see the Huntington disease patient. I'm convinced that we have Huntington disease patient. So we have two possibilities. Either we have the possibility of detecting the coding of Huntington disease patient with the DOH. But if it's underdiagnosed, of course, we are not going to get many patients. The other options is definitely to get access to the Emirati full genome sequences program and to try to test the IT15 gene for Huntington disease on the full set of the genes sequenced within the UAE, actually, within the Abu Dhabi Emirate. So, and I hope that, okay, let's get through it. Okay, maybe we can get at least, at the same time, the patients and the gene carriers to definitely launch a program, a research program and a care program for Huntington disease patients, starting with, okay, who are the patients and why are they underdiagnosed?
And with that, I would like to thank Dr. Pierre and Dr. Valeria for the very interesting and amazing presentations. Thank you all so much. And inshallah, if you ever end up in Abu Dhabi, we'd love to have you. Come give us a real life presentation.
Thank you very much.
Dr. Pierre is in Abu Dhabi, so hopefully when we see you in Abu Dhabi,
Thank
you can give
you.
us the same presentation. Looking
Good.
forward.
Thank you very much.
Thank you, thank you. And with that, we will now go to our next speaker, Dr. Fatima Al-Zahmi. I don't know if she's live, if she can hear me.
She's here.
Assalamu alaikum, Dr. Fatima. How are you?
Hi, I'm good, thank you. I think I don't know if they would allow me to start my video. Yes.
Yep.
Okay, good. And do I get to share my screen?
You do get to share your screen. Let me give you a quick, important introduction, and then the floor will be yours. So I actually had the pleasure of knowing Dr. Fatima now for almost five years, I would say. It seems like yesterday. As of November 2019, Dr. Fatima became the first and only Emirati neurologist who has dual training in stroke and neuromuscular medicine. She's also the only female Emirati physician who's American trained and certified as a stroke neurologist. Dr. Fatima Zahmi graduated from the UAE University, then went to the USA and Canada for further training. She's American board certified in both internal medicine and neurology. She's undertaken further fellowship training in 2 neurology subspecialties, vascular neurology, strokes, and neuromuscular neurology. Dr. Fatima is passionate about these 2 domains of neurology and is looking forward to providing the latest international standard of care for this patient population in the UAE. Dr. Fatima is particularly interested in stroke in young patients, including children, stroke in women, neurologic complications of medical conditions, and inflammatory myopathies. She conducts nerve conduction studies, EMGs, electromyographies, muscle studies, and Botox injection for migraines. With that, Dr. Fatima, the virtual floor is yours for 30 minutes.
Thank you for this very detailed introduction, and thank you for the organizers for inviting me to be part of this conference. And I'm happy to see some familiar faces. So I will be speaking about the rare neuromuscular conditions. So yes, my second subspecialty or my second passion is neuromuscular. I do more of autoimmune neuromuscular conditions, but I also get involved with hereditary conditions as well. So we're gonna start with a case presentation, which is not atypical for such a disease to present and on how it presents in adults. We're gonna then dive into the disease itself and recognize different spectrum of disease presentation. We'll go into the diagnostic testing and touch on the available treatment. So the case is about a 58-year-old man who presents to the emergency room with progressive shortness of breath for 2 weeks. So patient is interviewed by ER, internal medicine. He tells them that he has suggestive of orthopnea. He uses 2 pillows. He's a former smoker. He has a 2-year history of, feels a little weak in his proximal muscles. So difficulty doing stairs, difficulty reaching, up or using his arm above the shoulder level. He had an elevated CK, which did not seem to have an explanation, but it was passed. Now, in the emergency room, also, he's a former smoker, not sure about comorbidities, but he had an myocardial infarction a few years ago with a slightly reduced ejection fraction. They did an X-ray. There didn't seem to be, very much congested or severe edema, but he got admitted with provisional diagnosis of this respiratory failure, thought to be pulmonary edema secondary to heart failure. He's getting diuresed, but he's still needing non-invasive ventilation. He's still, despite the fact that the lung doesn't seem very congested, he is in a hypercarbonic respiratory failure. So that is when a neuromuscular weakness of the respiratory muscles was suspected. And from that on, he went further to have further testing. So such a presentation is not uncommon. So this is a, I can say, middle-aged man with a little bit of cardiac or cardiac comorbidities, and he's short of breath. Now, the interesting thing is that his shortness of breath or the degree of his respiratory failure was not explained or out of proportion to his heart failure or his being a former smoker, not COPD. So he did the lung testing, which is not obstructive pattern, it's more of the restrictive pattern or muscle weakness. So this respiratory muscle weakness out, or the respiratory failure out of proportion to his comorbidities. So respiratory muscle weakness, why would a man in his age have this disease? So eventually a patient was evaluated by a neurologist, further testing. 3 months later, he gets diagnosed with late onset Pompe disease, LOPD. So Pompe disease has several names to start with. So if you belong to pediatrics, you probably hear or use lysosomal storage disease more. And if you are in the adult world, you probably use glycogen storage disorder, glycogen storage type 2. You would call it acid maltase deficiency or acid alpha glucosidase deficiency. So why do we have these different names? It's basically because of the, and I'm not going to go into details. I know the audience is probably internists, primary care physicians, and general neurologists. So we keep it simple and so the multiple names because of the pathophysiology of the disease. So glycogen storage or metabolic, hereditary metabolic muscle disease. So the problem is you're not able to break down your glycogen into glucose, so you can use your glucose as a fuel, as energy source. The problem is that you have a deficiency, either absence or deficiency of the enzyme called alpha glucosidase enzyme. So this enzyme is present in the lysosome. So the lysosome has the enzyme GAA, which you need to break down your glycogen, so you can recycle your glucose. So it's not really like, I feel like it's not really a glycogen storage, it's a glycogen recycling or whatever, but that's the name, glycogen storage disorder type 2. So when I have a problem, then you're in the lysosome, you have accumulation of the glycogen, which will be seen as vacuoles if you do muscle biopsies, which we shouldn't do anymore. But historically, this is how it looked. And when you do specifically PAS stain, which I found that it's not done as a routine to all muscle biopsies, you actually have to ask for it. So if you are suspicious of a muscle glycogen storage disorder, whether it's type 2 or myocardial or other types, you ask for the PAS stain, and that will show you the accumulation of these glycogen vacuoles. So that's why it is both a lysosomal storage and a glycogen storage disease. So this way, we already finished with the pathophysiology of the disease. Now, what is the cause? What happens to why does the GA enzyme stop working? Well, if you need to have a genetic mutation, and the mutation has to be affecting both alleles that code for the enzyme. So it is an autosomal recessive. So you have to have a pathogenic mutation in both alleles. Most people would have a heterozygous or a compound mutation. So the carrier state for the carrier frequency is around 1 in 40,000, and this is the stats from the West, mainly the US. Could be more or less, depends where you are in the world. So if you're in 1 in 40,000, leads to a disease incidence of 1 in 140,000. So most of the time, because people would be carrying different pathogenic mutations. So most of the time it's 2 different mutations, but both of them cause disease. And there are more than 600 variants have been reported. So autosomal recessive, both parents have to be carrier. And it has a spectrum of presentation, and that depends. We have so many mutations. Some of them would lead to complete absence of enzyme activity. Some of them would lead to decreased enzyme activity to different levels. So the spectrum, the disease presentation will depend on how much enzyme activity do you have. So we believe that there is a correlation between when does the disease, so the severity of the disease, the age of onset, with the mutation, where the location is, and how much enzyme activity. So the infantile onset will have almost absent enzyme activity. Childhood juvenile onset will have some enzyme activity, but less than up to 6%. Now, in the adult onset, it's interesting because you would think that they would have more enzyme activity, but it's funny that we don't really have a clear correlation in the adult with the enzyme activity. So you would think, yes, I have more enzyme activity, close to the 30%, that's why it's an adult onset, but you could still have a very low enzyme activity similar to the childhood onset. So that remains to be explained or researched. So just another slide emphasizing the correlation between the enzyme, especially in children, or age of presentation. So very low activity, infantile onset, multi-system disease. So our lysosomes, or our need to use to break down your glycogen and to use glucose, is not only in the muscles, but also in pretty much every cell. So it's a multi-system disease, mainly the muscles, skeletal muscles, cardiac muscles, breathing muscles. Also smooth muscles are affected, and we'll see in the early onset or the infantile onset will have more of a multi-system disease because of the severity versus the late onset, which is mainly muscle disorder and respiratory insufficiency. So infantile onset is called infantile onset whenever they present less than 12 months of age with cardiomyopathy. If they present in the first year of life without cardiomyopathy, we call them late onset Pompe disease. So the infantile onset, they have hypotonia. Pediatricians are pretty good at suspecting and testing for Pompe disease as compared to adult physicians, neurologists or intensivists or internists. So yeah, that's why we have this diagnostic challenge in adult patients. But usually in infants or babies, if they have hypotonia, difficulty feeding, they're really quick at testing them for Pompe disease. So failure to thrive, respiratory distress, hypertrophic cardiomyopathy. Historically, it would be fatal by the age of 2, but in the presence of disease-modifying enzyme replacement therapy, now kids are living longer. As in the late onset, so you can have the juvenile onset, childhood onset, or adult onset. Or even if you had early onset, less than a year of age without cardiomyopathy, it's still considered late. It's under the category of late onset. Mostly skeletal muscle proximal weakness, but also significant proportion of patients would have respiratory muscle weakness. Also, a lot of these patients are significant involvement of the axial muscles. So you will have scoliosis, there are cases of head drop as a presentation. So again, this graph emphasizing the multi-system disease. So respiratory muscle, obviously it's a muscle, skeletal muscles, cardiac, but also the smooth muscles of the gastrointestinal tract. So patients can have, a lot of times it's not, if it's in kids, may have feeding difficulty or swallowing difficulty, but they can have like chronic constipation, chronic GI complaints, kind of non-specific in the adult life. The cardiac involvement, we do screen the adults, but it is uncommon to be present in adults. The muscle, not just muscle weakness, but they have significant muscle aches and pains. So partially functional mutations, respiratory weakness out of proportion. Yes, and the respiratory weakness does not have to be proportion to the skeletal muscle or limb weakness. It is not infrequent that these patients can have unexplained respiratory failure, respiratory weakness without really, especially early on, without detectable limb weakness. And it is a diagnostic challenge because as an adult neurologist or any, an internist or a primary care physician, the presentation is very variable. The patients can have muscle aches, or proximal muscle weakness, which is a lot of times dismissed as, oh, I'm just getting older. I think this patient was not really investigated for his proximal muscle weakness because he thought it's age related. And at the same time, you have other conditions. So first is am I suspecting a true muscle weakness or just, deconditioning, aging, muscle pains that are not specific? Don't call them fibromyalgia unless you have ruled out everything. Or even if you believe it is a true muscle disease, have been referred to a specialist, there is a wide range of differential diagnosis. Is this one of the limb-girdle muscular dystrophies that present late in life? Is this an inflammatory myopathies? Is this a statin related if a person like our patient is on statin? Could this be a neuromuscular junction disorder? Could this be ALS? So a wide differential diagnosis. Now, my main message from this presentation is that every patient, especially in the adults, I think the pediatricians do a good job at screening for Pompe, but in the adults, every patient with unexplained muscle weakness, respiratory insufficiency, or even elevated CK, unexplained elevated CK, deserves to be tested for Pompe, screened for Pompe disease. Well, the test is easy, and the fact that this is a treatable condition, it would be very, very sad to miss. So anyone with muscle weakness, high CK, or respiratory failure due to muscle weakness or respiratory muscle weakness, please do think of Pompe. Now, if the diagnosis is suspected, what do I do? Where do I move? Well, you really need to think of we listed a list of differential. So I always think, what do I want to rule out first? I always think, what are the most dangerous, so something that will lead to cardiac arrhythmias or conduction defect, and what are the treatable conditions that I can test for before anything else. So you have a wide differential diagnosis, test the conditions that you use specific testing for them. So the CK is easy to test in patients with Pompe. It's slightly elevated. It's not in thousands. Well, it can be like a little bit above 1,000, but it's usually in the few hundreds. Let's say the patient is, so this adult patient has muscle aches, slightly elevated CK, you really want to test for autoimmune conditions. So myositis panel and other connective tissue disorders. You really want to review the patient medications. Is he on statin, colchicine, long-term, some kind of antibiotic, whatever that could be toxic to muscles. And so you can initiate testing at the same time, have a low threshold to refer them to a specialist, a neurologist or a neuromuscular specialist. Meanwhile, if there is shortness of breath, you can also refer them to initiate the referral to the, either if you're the neurologist or the primary care, it's okay, even without confirming the diagnosis. If I suspect a muscle disorder, I always screen for the heart and the lungs. So when you refer them to a pulmonologist and ask for the forced vital capacity, usually forced vital capacity is part of the PFT test. However, MIB, maximum inspiratory pressure, and maximum expiratory pressures are not routinely done by the pulmonologist unless you ask them or you make sure that the referral is for neuromuscular weakness. So that's very important not to miss. You could also consider doing a sleep study if the patient has daytime fatigue and whatnot. Refer to cardiologist, get an echocardiogram and a rhythm analysis, echo or Holter. Something that I use very often, but I do use frequently is MRI of the muscles. So it's very important, especially if you have a radiologist with interest in muscle MRI, because there's certain appearance in the muscles and certain predilection to certain muscle groups that can be helpful to give you a clue. Also, if you consider muscle biopsy, you would choose the muscle according to where you think the most abnormal muscle is. Not the most abnormal, but mildly affected muscle, not so severe atrophy. And of course, neurophysiology testing with nerve studies and EMG. I did not mention muscle biopsy there, and it was on purpose. I think we have a lot of tests available that make us use muscle biopsies less and less. Not because yes, of course, it is invasive. It's not that invasive, but I think the accuracy of the other available tests will probably replace it. So very few occasions that we need to do a muscle biopsy. Most of the time, inflammatory muscles or when you're questioning two conditions. So before sending the patient for a muscle biopsy or considering, please do the dried blood spot test. It's easy, it's available. In UAE, it will not cost you anything because we have somebody, and I will mention that, they provide the test for free. So as I mentioned, muscle MRI, so especially with Pompe, there is an early predilection to affect the trunk muscles, so paraspinal and abdominal muscles. It also affects the proximal thigh muscles. It seems to spare the sartorius and gracilis muscles. So I like to do muscle MRIs. Now I am suspecting the diagnosis. I have checked for the conditions that could be in the differential diagnosis. How do I confirm? So confirming the diagnosis is two parts. You want to establish or show that there is low enzyme activity, and that's very easy, either by dried DBS, dried blood spot, or by a blood test, so leukocyte enzyme activity in the leukocytes. So that's a blood test. Or if these two are indeterminate or confusing results, you would consider sending it in tissue, so in skin fibroblasts or a muscle tissue. Once you have demonstrated absence or reduced enzyme activity, if you don't have a proband, if this is your first patient, I mean the first patient in the family, then you do the confirmatory gene sequencing for the GAA gene. Now, for follow-up, once you have this patient, I would also, you would screen the cardiac for cardiac involvement. Definitely the pulmonary function testing at least once every 6 months, at least once a year, I would say. I would also do, if there's any suspicion, I would do a sleep study. So it's not the classic snoring. These people have all the muscles. It's not obstructive. It's a sleep apnea, but it's not the obstructive type. And we're emphasizing testing or low threshold of testing because we do have a treatment that is disease modifying that will improve the patient. So the enzyme replacement therapy with alpha glucosidase is given intravenously every 2 weeks. The dosing is there. Don't need to know the details. You just need to have an expert that you can refer these patients to. Now, the expert who's treating this patient, or the center, hopefully, should also provide a multidisciplinary care team because it's not just giving the enzyme replacement therapy. A lot of times these patients will continue to need physiotherapy, occupational therapy. They might need to have some equipment or tools that help them manage at home. You need the pulmonologist, maybe the cardiologist, not very frequently. Do they need any dietary support? Do they need any speech evaluation, swallowing evaluation? So that's where it's important to have somebody who specializes and provide these multidisciplinary approach. Genetic counseling is important, especially in patients in the relatively young who would consider having children. So I thank Sanofi Genzyme for giving me these 2 examples of cases where this diagnosis was so challenging. This one patient presented initially at the age of it seems at the age of 39, but with different muscle aches, maybe weakness, and found to have elevated CK, got diagnosed with inflammatory myositis, treated, it took them 14 years to finally suspect the disease. Once you suspect, and the testing and the diagnosis, diagnosing the disease is very easy. So this patient went undiagnosed for 14 years.
3 minutes remaining, Dr. Fatima.
Thank you, Dr. Shatila. And the second patient, her journey was shorter, but it still remains significant. So she started having symptoms at the age of 22, and it took 3 years to reach diagnosis. I also was recently diagnosed a patient in my clinic who I believe the symptoms with muscle aches, slowly muscle weakness, and respiratory complaints for 15 years. He did have a muscle biopsy, but they did not stain for the PAS or the glycogen storage because it wasn't suspected, it was not requested, and the diagnosis was missed. But now he has a diagnosis. Now the diagnosis, so how do we confirm it? This dried blood test offered for free by the Sanofi Genzyme. And I think I don't know if I abuse it or overuse it, but I think as I said earlier, every patient deserves to have the screening. Every patient with unexplained muscle weakness, unexplained high CK, or respiratory insufficiency. It's an easy test, doesn't cost anything, and it's a screening. If you find decreased activity, they also provide the genetic testing for the GA. So, in summary, challenging to diagnose the symptoms. There's a spectrum of presentation from early infancy to adulthood, multi-system disease, and have a low threshold to test because it is treatable. And that's it. I think I did good with the timing. Thank you. We'll have the discussion after. Is that correct?
Thank you, Dr. Fatima. Right on time, actually. Actually, you're 1 minute early. Thank you. So we'll hold up. I'm sorry.
Perfect. Thank you, Fatima, for being with us. Please stay with us till the end for the questions. And now we will move to our next talk, and it's my pleasure and honor to introduce Dr. Ahmed Shatila, my colleague and co-chair. Dr. Ahmed Shatila is known to all of you, I guess, hence he does not need an introduction, but we'll do it for the formality. So he had his medical degree from Wayne State University in the United States, and then he completed his residency and neurophysiology fellowship at the Detroit Medical Center in USA. He has many years of experience. I'm not going to say the number. He certainly looks much younger than the number. And, he's been treating all sorts of, neurology patients in the adult world. He has a special interest in multiple sclerosis, as many of you know, and he manages the MS clinic, multiple sclerosis clinic in SSMC. He's really an authority in this field with, all of us referring patients to him. In addition, he's dedicated to spreading the public awareness about neurological disorders. He's a big advocate to people with disability. In addition to all his clinical work, he is also interested in academic and research and publication, and he's a speaker at many local and international conferences. Today, Dr. Shatila is going off his hat, and he will talk to us about a disease that he does not usually talk about, but I'm sure he will give us a great presentation as usual. Fabry disease from neurologic perspective. Thank you, Ahmed. The floor is yours.
Thank you, Dr. Jihan, for the very kind and nice introduction. So as Dr. Jihan said, I had to mention, I'm going to talk today about clues for an early diagnosis by neurologists, but also not just limited to neurologists. Primary care, intensivists, GPs, really it's a spectrum throughout the entire medical field, because this disease is not just dedicated only to neurologists. It affects really every field of medicine. And that's why it's so important to talk about this today. I'm going to talk about Fabry's disease. So I'm going to start off first with a clinical case, because it's nice to talk about cases. This is a 69-year-old female. She comes in for a consult for second opinion, was recently diagnosed with MS, and incidentally, different findings of her brains were done because she had headaches. And then we see it all the time, second opinion, there's these unidentified bright objects on MRI. No signs of motor deficiencies, no cognitive decline. She has some mild proteinuria, stage 3 chronic kidney disease. She has atrial fibrillation and left ventricular hypertrophy, and she's got neuropathy in her hands and feet, mainly during childhood. Now, when you look at the MRI, let me turn on the timer, because I sometimes talk a little bit too much. Sorry about that. There we go. Okay, when you look at the MRI, you see these white matter lesions. Some of them are periventricular. There's an infratentorial lesion at the pons. You can see it's a very well circumscribed lesion, and it's not atypical. We see this routinely in our MS patients. But is this MS? And this is the whole purpose of this presentation, is to sometimes, when you hear hoofs, you think of horses, but every now and then you think of zebras. And I'm going to talk to you today about some zebras. So we're going to talk about Fabry's disease. It's been well established that Fabry's disease is underestimated in the differential diagnosis of MS. Why? Because it can look like MS. You have the typical periventricular, you can have juxtacortical intratentorial lesions, but that's where the disease stops. It's been reported multiple times with MS, and we have testing showing the ability to diagnose Fabry's disease. In this study right here, the usefulness of lyso, global triacyl sphingosine and dried blood spots, the differential diagnosis between MS and Anderson's Fabry's disease. So when did Fabry's disease first get diagnosed, or when did people start even recognizing it? It happened in 1898 when Johannes Fabry's and William Anderson first independently described it by dermatologists. Then in 1947, it was recognized as a lipid storage disorder. In 1963, people began to realize that this is because of an accumulation of GL3 and GL2, which is in the renal tissues. And then in 1965, so almost 68 years later, it was found out to be X-linked inheritance. And then it wasn't until 1973, so almost 75 years later, 3/4 of a century, where then now we know exactly what's wrong. And it's basically you have a deficiency of alpha-galactosidase A. It's an enzyme which was involved in which permitted the enzymatic diagnosis of Fabry. Mutations in the GLA gene leads to a deficient in alpha-galactosidase A. So as I was telling you, you've got defect in the genes encoding GAL-A, I'm going to call it A, and then that deficiency causes, you have deficiency in the activity of the alpha-galactosidase activity, which then causes an increase or accumulation in GL3 as well as GL2. Now, this accumulation is not just specified to the brain or to the renal, it's multi-organ. So depending where the accumulation occurs, that's where the symptoms will develop. And that's where it gets really hard to diagnose it because it's multi-organ. And the ongoing accumulation, you get this cascade of events, kidney, heart, CNS problems. And now, organs that are affected by Fabry. Again, this is a hard disease to diagnose. And actually, just to give you an idea, there's only 3 cases in the United Arab Emirates with Fabry disease diagnosed, and they were diagnosed when they had renal problems. So more towards the end stage. Now, why is that important? Because when I was reading about it, it has a prevalence or an incidence of about 2 in 100,000. So that means 20 per million. UAE population, we're 10 million people. So you're expecting around 200 people with this disorder. But yet, we only have 3 people in the country. So you know that we are underdiagnosing it. And the problem is, it's multi-organ. So, you know, these patients may present to the neurologist, the cardiologist, the nephrologist, my primary care colleagues. So again, we have to really think out of the box. And, you know, people coming in with a wide variety of symptoms, we have to think of Fabry. You get altered blood flow in the brain. This increases your risk of strokes. You've got cardiac problems causing dyspnea, chest pain, fainting, palpitations due to arrhythmias. End stage, you get the renal abnormalities, dysfunction causing dialysis. It's not uncommon that people initially may present with acroparesthesias or burning in their hands and feet, just peripherally. They may also have rashes or inability to sweat, diarrhea, pain, bloating, constipation, hearing loss, tinnitus, vertigo, and as well as cornea, retinal, and lens problem. So again, there is no one way, there's no one checklist to say, okay, you have these, you have Fabry. You really have to think out of the box for this disorder because like I said, it has to exist, we're just not picking it up. And if we only have 3 patients in the country, we're definitely underdiagnosing it. So how's it inherited? It's X-linked, meaning that if you don't have the gene, you don't have the disease. If you have the gene, it's on the X chromosome. That means for men, you got XY, and on women, you got XX. So in women, if you have the gene, you're going to present with if you have the gene on your X chromosome, you're going to have the disease. But that means 50% of your daughters will have the disease, and you'll have 50% of your sons will have the disease. Now, if a male or affected father has the affected gene, all of his daughters will have the disease, but none of his sons. So why is that important? Because on average, studies have shown that for every 1 diagnosis of Fabry, there's around 5 other people in the family that may have it. So again, if we have 3, that means there should be 15 other people that we're missing. And again, we're missing those people, and we're on average, there's around 60% of the people who have it are women, and 39% of the people who have it are men. There's 2 ways that this disease can present itself. You've got early Fabry disease, which is not that common. 2 to 14% of all Fabry patients will present with early Fabry disease, and that's where our pediatric colleagues or pediatricians will help us diagnose that. Again, high index of suspicion. The higher incidence of Fabry patients are the late onset mutations, and that's where they come in with multiple other symptoms, and that's where we're saying you got the classic, but really that's just the tip of the iceberg. You've got the late onset that presents with multiple problems. Now, you've got pain, GI problems, hyperhidrosis, sensory loss, headaches, depression. All of these, you could, due to the accumulation, as I said, of the GL3 deposits due to the inactivity of alpha-galactosidase A enzyme activity, increases your risk of strokes, TIAs, incidental white matter lesions, which is not uncommon that we see in our MS populations. And this can cause abnormalities in cranial vessels. All of this leads to premature death. What's the typical diagnostic delay in life expectancy? On average, in men, the first symptoms start at around 9 years of age. In women, it's 13 years. But even though their symptoms start at 9, there's around 11 years delay in men for diagnosis and 14-year delay in women for diagnosis. In total, it can sometimes take, they won't get, even though their symptoms start at 9 in men, they don't get diagnosed till 24. Women, they don't get diagnosed till 31. So again, when you look at the chart on the graphs on the right, when you plot the life expectancy for different sexes across their age, you can see there's a clear difference between normal population versus the Fabry's. It's a linear regression. You know, as you get older, less people with Fabry's live and survive, and overall lower life expectancy at any point in time. A little less for women, but still exists. What are the neurologic signs of Fabry's? CNS, you get strokes, hemorrhagic strokes, you get these white matter lesions. Peripheral neuropathies, the acroparesthesias, pins and needles, mainly in the tip of the fingers and tip of the feet. They get autonomic neuropathies, hearing impairment, and vertigo. On the MRI, what do you see? You get this dilated and tortuous vessels. You get multiple white matter lesions in the cerebral hemispheres. Again, you see that now. I think one of the most important things is someone with multiple white matter lesions without any clear attacks indicative of a MS, you have to think maybe this isn't MS. If they're young, maybe this is a metachromatic or leukodystrophy, as Dr. Valeria was saying. If they're older, or not even older, if any age, you may want to think of Fabry's disease. Neurologic signs and symptoms are frequently reported manifestations in patients with the disease. Fabry's disease affects both the peripheral and the central nervous system. The neuropathies are the most common early symptoms. This is again due to the accumulation of the GL3 and the somatic and autonomic nerves of autonomic nerves. These neuropathic symptoms are also often followed by strokes, complication, and progression of autonomic dysfunction. I already talked about the other peripherals, so I will skip that. Small fiber neuropathies. Because they get this small fiber neuropathy or pins and needles, meaning that if you do a nerve conduction study, it may be normal because nerve conduction studies look at the large fiber. And a small fiber neuropathy, it's like your diabetic neuropathy, pins and needles, pains, worse at night sometimes, tip of the fingers, tip of the toes with a normal NCS, and someone who doesn't have diabetes, and someone who doesn't have any comorbid conditions such as alcohol or any autoimmune disorder, you have to think of Fabry's because, again, it may be present in a high proportion of people. And this is what I was talking about, the acroparesthesias. It tends to be an early symptom. Patients suffer from the neuropathic pain, crisis, burning, and piercing pain. It's usually due to the small fibers, which means that your nerve conduction study is normal. And the pain usually begins in the hands and feet and radiates proximally, usually with your dipole. On another note, usually with our diabetic patients, the rule of thumb that I always taught when I was a resident usually starts off, it's length dependent. Starts off in the toes, and usually the way I always learn is by the time the neuropathy gets to the knees, that's when the fingers start to get involved. In Fabry's, it's really systemic. All nerves are being affected at around the same time. So there's no predilection for long nerves or short nerves. That's why you can get the hands and feet happening at the same time. Again, another thing to keep in mind. What are the central nervous system manifestations? Again, you can get hyperintensities in the pulvinar. You can see on the MRI, the two big arrows pointing to the pulvinar. Those are the hyperintensities, extremely subtle, but you know, you get it. I guess hindsight's 20/20. If you know or you suspect it, you'll see it. But you know, these subtle things can even be missed by our radiology colleagues. That's why it's important to look at your own images. That's something I tell all my students, all my residents. It's not normal, it's not abnormal until you say it's abnormal. Now that I don't trust my radiology colleagues, I just need to have confidence in myself that I'm seeing what they see. You also get the dilated tortuous vessels on the MRI in the middle, and you got a hyperintense lesion on the cortical affecting the U fibers. MS tends to affect the U fibers as well. And again, it can look very much like MS. So you got to have a high suspicion for Fabry's. Overview of CNS manifestations, think of strokes and TIAs, abnormalities in the MRI, white matter lesions, headache, psychiatric illness, mood disorders, behavioral changes, and depression. Now, we focused on stroke because stroke is important. Why is that important? Because almost 40%, the age of first stroke was 40 years in men and 45 years in women. And in any country, in any region, that's a young population. So if you're getting a person in their 40s or even mid-45s with a stroke of unknown origin, cryptogenic, think of something else. Think, maybe this is avasculitis. Maybe this is a lysosomal storage disease. Maybe it's Fabry's. Again, and the stroke, now, what proportion of people had strokes before any renal or cardiac event? 70% of men had the stroke before they presented with any other systemic involvements. And that's important because by the time they go to our nephrology colleagues, they're already on dialysis, and the damage is done. And 3/4 of the women also have strokes before even they have dialysis or any cardiac involvement. At what age? 22% of stroke patients had strokes before the age of 30. Again, extremely young population. To have a stroke in anyone in their 30s without drugs, without any other reason, you have to think maybe you just can't, if you can't explain it, we have to be looking for it. And if our diagnosis or if our workups just stops with MRA, lipids, and an echo, you're never going to find these other rare causes of strokes. The stroke incidence is markedly higher versus the general population for all age groups. Now in this bar graph, you can see that between 20 to 40, almost half of all of the strokes were due to Fabry's, or actually a very high proportion of strokes in young people were due to Fabry's. Neuropathic pain is one of the most prevalent and early signs and symptoms of Fabry's disease. The median age of onset is 17 years of age. 65 to 81% of patients have pain regularly, most commonly located in hands and feet. Chronic pain, pain attacks, joint pain, abdominal pain. And they may come to our primary care colleagues, our internists, our rheumatologists complain, and maybe they get diagnosed as fibromyalgia, maybe not. But I think this is where it's very important to look at, not just, sometimes we get focused in our field and we don't focus on the other organ systems. So it's important to think, is there something else going on? Especially when you can't explain these rare, weird symptoms. The pain interferes with daily activities, has a significant impact on quality of life, starting from a young age. What's the prevalence of Fabry's disease in patients with cryptogenic strokes? There's a high frequency of Fabry's disease in a cohort of patients with cryptogenic strokes, with about 1.2% in young stroke patients. Fabry's disease must be considered in all cases of unexplained strokes in young patients in the vertebral-basal artery system and proteinuria, water. Now, like I said, I haven't diagnosed the Fabry's disorder yet, but I'm always looking for that patient who may have Fabry's. Young patient, neuropathy, not diabetic, any young stroke, any unexplained white matter lesions with the absence of any clinical attacks. I will send out the blood spot to Sanofi to get the free testing for Fabry's. I haven't found that patient yet, but if you look for it, or if you think of it, you will find it. And I would say the eyes don't see what the mind doesn't know. So you have to think about it. How do you identify? Again, it can be very hard. You've got diffusion restriction. It can look like a stroke. You can have this large vessel stroke. You can have more of this mottled type, embolic type of lesion. So really, you just have to think about it, especially in a young patient. Less than 40 years old with strokes, you have to think something else. Stroke is an early indicator of Fabry's. Stroke may be the first manifestation of Fabry's disease prior to the patient exhibiting any other major findings. In one study, 50% or almost 45% of stroke patients with Fabry's disease experienced their first stroke before diagnosis. So again, you're going to say, you pick it up, we diagnose it, maybe we can prevent the second stroke from occurring. Stroke may be a significant cause for premature death in Fabry's disease. As I showed you, when you look at the bar plots, at every age group, people with Fabry's disease die younger than their normal cohorts of friends who don't have Fabry's. In a study investigating the natural course of Fabry's disease, stroke was reported in 45%, and TIAs in almost a third of patients who died. And stroke in patients with Fabry's disease follows all known pathophysiologies. So how do you identify Fabry's population or Fabry's patients in a stroke? If you have suffered a stroke, mainly less than 50, test for Fabry's. It's an easy test. It's just a blood. It's just, you got 6 blood spots on a piece of paper. It's done for free. You get the diagnosis. And if you think about it, you may find it because, like I said, it's extremely underdiagnosed only because none of us have seen it. Cerebrovascular events are observed with similar frequency in male and female. So the incidence of strokes and TIAs in males and females that were involved in the study. 9% of stroke patients, 9% of men who had stroke were men, or 9% of all strokes were men, 5% were women. TIAs also, there's a high preponderance or prevalence in strokes or TIAs in men and women due to Fabry's. 45% of patients reported their first stroke before being diagnosed, as I just said, and observed frequency of strokes among males aged 25 to 44 is approximately 12 times the expected general population. I said that abnormality, you've got the pulmonar T1 hyperintensities in the pulmonar region of the thalamus. You've got tortuous vessels and abnormality, ectatic vessels. A lot of times we see these things and it's just reported as normal variant. Maybe it's Fabry's, maybe it's not, I don't know. But I mean, we have to think about it. And maybe it's not normal, maybe we're just calling it normal, or we're not looking at it with a different set of eyes. And as well, flare-weighted MRI, you got right-sided mutal artery infarctions. You can have left-sided white matter lesions. So how can we tailor the screening? So again, it's not practical to send out the blood spot testing for every single patient who comes to our clinic. You may see thousands. The guys at Sanofi are going to hate you next time you give them 200 tests for Fabry's. So here's a quick questionnaire. And if you have 3 yeses, then it may warrant you to check for Fabry's disease or send out this test. It's not one of those, you want to increase your yield. You don't want to just send it out for every neuropathy patient or everyone who shows up in your clinic with AFib. So does your patient or family member, do you have any family members with current symptoms? Do you have a family history of young deaths due to cardiac, renal, or cerebrovascular disease? Do you have small red spots in the genital and periumbilical region? Do you feel pain or burning sensation in your hands and feet, mainly during exercise or fever? Do you see any periodical edema, swelling in the feet? Do you feel any periodical dizziness or decrease in your hearing capacity? Do you have any abdominal pain, episodes of frequent diarrhea during childhood? Do you notice any absence or reduction in bodily sweating? And that's actually important. We live in the UAE, so if you're not sweating in the UAE, there's probably something wrong. Check for neuropathies. And if you're checking for neuropathy, check for Fabry's, because one of the signs of neuropathies, especially with the autonomic neuropathies, is erectile dysfunction, GI dysmotility, and abnormal sweating. So think about that. Do you have a diagnosis of stroke before 45 years of age? Or multiple sclerosis? Maybe it's especially familial MS. Maybe our familiar MSs are not all familiar. Do you have a diagnosis of loss of protein in urine, proteinuria, or chronic kidney disease? So in summary, stroke may be the first manifestation of Fabry's disease before any other typical signs. 50% of male patients and 50% of male patients. Stroke was the first manifestation of Fabry's disease. Fabry's disease must be considered in all cases of strokes in young adults, less than 50, but if you want to get even more particular, less than 40. The incidence of Fabry's disease in the young population, 18 to 55 years of age, was around 0.5 to 1.2%. The precise mechanism underlying stroke and Fabry's disease is not exactly certain, but maybe it's due to the accumulation of the GL3 deposits, due to the lack of alpha-galactosidase A enzyme activity. Fabry disease patients show various pathologic changes, so you have to think about it, both in the cerebral blood flow, intracranial vessels, as well as vasculopathy affecting both the intima and the media of the arteries. And then finally, cardioembolic mechanisms may contribute to strokes and Fabry disease. And there's another number of mechanisms that may contribute to the vasculopathy. So that's it. It's an extremely hard diagnosis. It's not, I mean, like I said, we're definitely underdiagnosing it, but you have to think about it. Anybody with cardiac arrhythmias, renal problems, young age, family history of same disorders, think of Fabry's. For our neurology colleagues, small fiber neuropathies, without diabetes, without any autoimmune vasculitic process, you may want to think of Fabry's. Any stroke in a young patient, outside of drugs, outside of any vasculitis, outside of moya or any vasculopathy, think of Fabry's. Like I said, I do check it. I haven't found that patient yet, but you know, if you think about it, you may find it. And if you find it, it's important because then you can treat it. Thank you very much. So,
thank you, Ahmed, for a very comprehensive talk. It's a lot of information, and you did very well with the time also. Thank you.
Thank you, Dr. Jones. So with that, I will now present you. You are our last speaker, last but not least. We've definitely saved our most interesting topic and our probably, hopefully, the best person able to talk about this topic, hopefully, will be you, because this is a multi-systemic disease. And this, the whole purpose of the second aspect of this meeting was multi-systemic diseases that can carry a lot of mass, have a lot of different flavors. So you have to think about it, you know. So a little short biography about Dr. Jihan. Dr. June-11 is a consultant and division chief pediatric neurologist at Duam Hospital. She's also associate professor of pediatrics at United Arab Emirates University in Al Ain, UAE. Dr. Sulaiman completed her specialization in pediatrics and pediatric neurology at Children's Hospital. Oh, wait. Oh, at we're blinked up. Oh, pediatric neurology in Westmead, Sydney, Australia. The image closed. She holds the fellowship of the Royal Australian College of Physicians, FRACP in pediatrics and pediatric neurology. She has a PhD in medicine in the field of neuroimmunology from the University of Sydney, Australia. Her clinical interests include neuroimmunology, neuroradiology, neurogenetics. She's also interested in complex epilepsy and its management. She has academic and research interests in the fields of pediatric neuroimmunology, neurogenetics, and has many publications. Today, Dr. Jihan is going to talk to us about cerebral tendinous xanthomatosis. Hope I'm saying that name correct. And with that, the floor is yours.
Thank you very much, Ahmed, and thank you for everyone for staying with us till the end. And I am aware I'm the last speaker and you're probably already tired, so I will try to be, not hold you back for too long. The disease I'm going to talk about, cerebrotendinous xanthomatosis, is also following the theme that we chose, diseases that can affect children as well as adults. So I will be aiming to provide a quick and focused review of a rare but also underdiagnosed and potentially treatable disorder, like the continuum of the disorder in both adults and children. And I will talk quickly about epidemiology, but more on clinical characteristic to help us identify this disorder and test for it, and the diagnosis, and quickly on the treatment available. So CTX is a rare and underdiagnosed autosomal recessive disorder, and it's actually caused by an inherited defect in the metabolic pathway of cholesterol. This results in a defect in bile acid synthesis and causes cholesterol accumulation. So if you carry on these 3 sentences with you out of my talk, this is the whole pathophysiology of the disorder. I will tell you more about it because it's caused by a mutation in the gene called CYP27A1 gene. You don't have to remember it. I also don't remember names of genes, as long as we know that what we are talking about and look it up when we want to test for it. This gene encodes steroid 27 hydroxylase, an enzyme involved in the cholesterol breakdown and bile acid synthesis. So the main problem that results from the loss of function of this enzyme is the reduction in primary bile acids, and in particular, one of them called pinodeoxycholic acid, CDCA. You remember this name because this is the treatment we will provide for these patients. And then subsequently, any enzyme defect will result to buildup of metabolites of the precursor. And in this case, we have buildup of cholestanol, which will be deposited in multiple organs and resulting in a multisystemic disorder. So you can look at it from multiple angles, depending on your specialty. Our GI colleagues probably will see it as an inborn error of bile acid synthesis. Our genetic metabolic physician will look at it as a lipid storage disorder because there is deposition of the fat and fat metabolites in various tissues. Probably we as a neurologist might see it as a leukodystrophy because there are changes in the white matter with this disease. So it is rare. There is about 400 people reported, so it's certainly underdiagnosed, and so many cases are there without a diagnosis. In the countries with the studies, the prevalence is really variable. So it can be from 1 in 30,000, such as in South Asia, to 1 in 200 or 400,000 in Europe. However, it is of note that there are certain communities where the disease is so prevalent and common, especially those with multi-generation consanguinity, such as the Jews of Morocco, where it's as frequent as 1 in 100. And in the Druze Arab community of Palestine, it's 1 in 400. So as I said, for the pathophysiology, we have the gene mutation resulting in an enzyme reduction of activity, leading to impaired bile synthesis, leading to reduction in choledoxycholic acid, as well as cholic acid. And then because of the loss of negative feedback, we have metabolites that are harmful, cholestanol and bile alcohols, and these will accumulate in the brain, lenses and tendons. For those who like a visual illustration, this is the pathway. By no means I'm gonna go into the details, but you can see that cholesterol will not really be metabolized into the cholic and the choledoxycholic acid, and the intermediate metabolites will accumulate and cause a problem. So I want you to remember the 4 cardinal clinical features of this disorder, which, as I said, will go through different ages. We will talk about that. So we have, number 1 is infantile onset chronic diarrhea, and this diarrhea is often refractory and long-term. It's not a diarrhea of, gastroenteritis or malabsorption. These patients often go and have multiple, investigations looking for the cause, and no cause is identified. The second feature is cataract, and the cataracts are usually bilateral, and they are premature. They affect the young individual. These are not congenital. They usually start after the age of 2 to 3 years. The fourth feature is tendinxanthomas, and often by that stage, when the tendinxanthomas are seen, because they are external and obvious, the diagnosis might be suspected. And finally, which is, the reason we're talking about this disorder in our NERD, is the progressive neurological deterioration. And unfortunately, by the time we reach this stage, it's often quite late, and we might not be very successful in reversing symptoms and signs. However, not all patients will have all the four great features. Some will have one or two, some will have maybe more. And even within the same family, the manifestations will be variable, and the severity as well, and the age of onset of each manifestation. So much variability, and that makes really the diagnosis also more difficult to make. Suspicion is important, like all the disorders we are presenting today. And so if you are really suspecting it, the diagnosis is simple via a blood test for cholesterol or a urine test for bile alcohol, and then confirmatory testing always by genetic testing. Unfortunately, if untreated, this disorder is often associated with death or reduced life expectancy. So the blue arrows are the four cardinal features I talked to you about, and you can see from birth, the chronic diarrhea can start. Few years later, we can have the cataract. About the age of, as early as 14 and 15, you might start to see tendinopathies, although they tend to occur a bit later. And the neurological impairment, it can start early with learning difficulty, developmental delay, but often progresses and really result in disability, dementia, and even bedridden. If you look at the age, so the main age of onset of symptoms is 9.5 years. However, the mean age for diagnosis is 35 years. So we're talking about 25 plus years of missed diagnosis. And as we mentioned, the life expectancy is reduced. And important to remember that not all patients will have all these manifestations. Some people talk about stages. So the stage 1 is the early, many children might have prolonged neonatal cholestasis. If you are really good at taking history, and often, if you have a medical student who can go and take detailed history about also, if you're seeing, I guess for our adult colleagues, if you're seeing an adult patient, you might not dig deep into their neonatal history, neonatal cholestasis, but it is one of the features. And then also chronic diarrhea in infancy or in childhood might be missed if you're seeing the patient at the age of 20 or 30 or 40. And then premature cataract should really stand out if it is there, because it often requires surgery. And our ophthalmology colleagues need to be aware of this condition when seeing bilateral premature cataract to think about the disorder, because it might be the only manifestation by that time. And then stage 2 is when you have development of neurological symptoms, which we will come to the details of. So variable really, pyramidal, cerebellar, learning difficulty, cognitive impairment, and decline as well. So there is progress in the disease. There is also axonal polyneuropathy, which can be present and detected also in nerve conduction and EMG. But psychiatric disturbance, aggression, agitation is also an important feature. So apart from the neurological condition, we talked about the hepatic prolonged cholestasis. We talked about the ocular, in particular premature cataracts, diarrhea in the GI, and tendons and tumors. Other rare manifestations include osteoporosis, but also cardiac complication, including atherosclerosis from deposition into the blood vessels. And again, this is just the same thing we're talking about, maybe more animated. We added the osteoporosis and atherosclerosis at the end of this slides, just to really keep you visually stimulated of the different manifestation. Any of those should really prompt you to think of this disorder. And unfortunately, left untreated, we see all the features we've spoken about. Epilepsy is also one of the manifestations, and eventually progressive neuropsychiatric impairment and becoming bedridden. When we talk about the neurological findings, The most common thing is extrapyramidal symptoms, such as tremor, dysdiadochokinesia, some coordination difficulties. Next is intellectual disability as well as decline. Ataxia and gait disturbance is a prominent feature. Other cerebellar signs such as nystagmus, polyneuropathy, and seizures seem to be the least. Just to give you some pictures of the cataract, quite impressive, but then also the tendon xanthomas and how they look like, and they usually found in the Achilles tendon. So if you get into the habit when you're checking your reflex, ankle jerk, just look where you are tapping, and you might find a big xanthoma in that tendon. Just to give you some clinical perspective, this is a study from Turkey where there is more cases than so I found a mutation there. And this is a study of 6 patients. And you see, they didn't do too badly, really. The age of diagnosis, they all were children below the age of 18. And some of them had cataract as a presenting symptom, some of them had diarrhea, and some had developmental delay. And you can see that 3 out of the 6 eventually had cataracts. Some of them had, cognitive deficit, cerebellar involvement, peripheral neuropathy. It's quite variable. Behavioral change, aggressive behavior. And this is just a summary of them. Skeletal findings, as I mentioned, osteoporosis, and in some of them leading to multiple pathogenic fractures. So talking about the neurological findings, dysmetria and dysdiadochokinesia, ataxia, and peripheral neuropathy found on EMG. Cognitive deficit, IQ scoring normal in some, but attention deficit and school learning and difficulties, depression, psychiatric manifestations, aggressive behavior, as I mentioned. So quite really variable that can be seen in so many disorders, these neurological manifestations. So like Ahmed has shown us nicely how to really go through certain checkbox to narrow your thoughts. The same thing we have for CTX, and this is the Minari Suspicion Index, and it's based on the 4 criteria that I mentioned. And so if you have 2 out of these 4 criteria, you should really go ahead and carry the diagnostic tests. Not only that, there is also a form that you can also check what your patient really is having. So for example, having a sibling with CTX already gives you 100 points. So using this form, if some criteria give you 100, the next column give you 50, the last one give you 25. And it's recommended if a total score of 100 or higher, then a diagnostic test should be performed. So if there is a sibling with CTX, this is enough for you to perform. Now, if there is a tendon xanthoma, it's also a very specific and unique feature that's enough for you to go and go ahead with the testing. If you have other things, consanguinity, juvenile cataract, childhood onset diarrhea, prolonged unexplained neonatal jaundice, ataxia, MRI, evidence of dentate nucleus signal alteration, which I will talk to you about later, or intellectual disability. These are strong features. Each of them will give you 50. So 2 out of those, 7 features is also enough. Less specific features include early osteoporosis, epilepsy, Parkinsonism, and polyneuropathy. Each of those will give you 25. So this form is available and you can use it when you have suspicion. And this is just to show you in patients who had the Minari scoring applied to them. The most common feature was intellectual disability and psych disturbance, followed by cataract, followed by ataxia, and the presence of consanguinity, and then tendon xanthomas. These are the most common or specific findings. Now, how do you diagnose CTX? You've got the clinical features, you've got enough reason to suspect. You need to test a blood test for cholesterol level. And it has to be 5 to 10 times higher than the normal. And this is highly specific for CTX diagnosis. Another test is urine, but it's not very specific. So there will be increased bile alcohols, but some other bile acid metabolism disorders might result in a similar thing. And once you have, plasma cholesterol elevation, you go ahead and do the molecular testing. And for the gene CYP27A1, there has been about 100 different mutations reported, pathogenic mutations. Most of them are missense, and some are common in certain, countries and ethnicities, and particularly in the Arab Druze population, they have found a mutation, and hence they probably carry a higher incidence. Moving to the imaging features. So when you do MRI, you will find in most of these patients a signal abnormality, hyperintensity in flare, indentate nuclei, bilateral symmetries, and plus minus mild cerebellar atrophy. Some patients will also have white matter lesions. I'll show you in the next slide. It's often periventricular. And when you do MR spectroscopy, and I am a very big advocate for if you're doing MRI, if you're suspecting any genetic or metabolic disorder, do MRI spectroscopy. It might really be of additional help. So there will be reduced in acetyl aspartate, suggestive of diffuse axonal injury that you cannot see on MRI, and also lactate peak, which suggests diffuse mitochondrial dysfunction. So on the left side slide, you see the bilateral dentate nucleus signal abnormality in the cerebellum. And on the right side, you see the bilateral, quite asymmetric, not really like the MLD or other more impressive leukodystrophies, but there is periventricular white matter abnormality that one might see and think it's even looking like multiple sclerosis. And some patients will have cerebellar, but also generalized brain atrophy, not shown in these images. When you do the MRI spectroscopy for the periventricular matter, white matter lesions, see there is the right-sided is a control, a normal patient, and the one on the left is a patient with CTX, and you see the reduced peak of NNA suggestive of diffuse axonal injury, and you see the higher lactate peak suggestive of mitochondrial dysfunction. So this disorder is treatable, and ketodeoxycholic acid is the standard treatment. And there has been studies that demonstrated that, starting the treatment at any stage, but of course, if you start early, you're going to see better outcome, and it affects the natural history of the disease. If you have an early diagnosis, initiate therapy before the onset of significant neurological disease, then you might be able to stop the neurological disease altogether. But even patients who were diagnosed later and already had some, significant neurological disease, they might improve a little bit or moderately, but at least they will remain stable and not progress. But some of them progress despite therapy. So you're really best win if you're diagnosed early. And so that's the same Turkish study, which really applied the treatment to the 6 patients we talked about. The treatment was CDCA, 10 milligram per kilo per day. And you see the variable age of starting the treatment following the diagnosis. Patient 6 did not have any neurological manifestation, just mild developmental delay. But you see patient 1, who was 17, had a slight improvement in his ataxic gait and his psychiatric disorder and tremor stabilized. And similar findings were really with the other patients, either some improvement or stabilization. So just to remind you, there are 4 criteria: intractable diarrhea, bilateral juvenile cataract, tendinopathies, neurological abnormalities. If you encounter 2 or more, please think of this disease, CTX, cerebrotendinous xanthomatosis. It's a treatable disease, and early recognition and treatment may lead to a life free of disability. With that, I will leave you with a short video, which really demonstrates, it's like telling you a story of a family of few siblings with the disorder. I thought it will be better than just keep talking. So please enjoy the video.
Cerebrotendinous xanthomatosis is a rare and inherited neurometabolic disease. Treatment is possible, but due to low awareness, there is an average of 19 years delay in diagnosis. Early diagnosis is essential in CTX disease, where many neurological and systemic symptoms can dominate the clinical picture, from the asymptomatic disease in early childhood to severe disability in adulthood. In this video, the medical history of 2 siblings with late diagnosis of CTX and whose treatment was delayed will be shared. In the neurological examination of a 33-year-old male who applied to the neurology outpatient clinic with the complaints of difficulty in walking and imbalance, he had severe bilateral ataxia, requiring continuous support when walking. The patient stated that this complaint started 8 years previously. The imbalance had become progressively more severe, and he could not walk without assistance for the last 2 years. Inability to perform daily tasks due to the increasing tremor and difficulty in using hands, along with bilateral imbalance while walking. Within 1 to 2 years, deterioration in speech, inability to walk or even stand without assistance. In the last 2 to 3 years, he had lower extremity contractions and an inability to fully extend the knees, causing gait disturbance, forgetfulness, inability to remember the names of friends or acquaintances or recent events. According to the medical history of the patient, he developed bilateral blurred vision at the age of 16, and he underwent bilateral cataract surgery at the age of 17. According to the information obtained from the patient's mother, the patient was delivered vaginally but treated in the neonatal intensive care unit due to neonatal jaundice. The patient has a bedridden sibling 3 years younger. When we look at neurological examination findings, dysarthria, prominent nystagmus on lateral gaze. In both upper extremities, dysmetria, dystiodocokinesia, intentional tremor, and hypotonia have been detected. The patient cannot stand and walk without assistance due to severe ataxia. Bilateral imbalance, dysarthria, bilateral dysmetria, and intentional tremor were also present. Bilateral positive Babinski sign, brisk deep tendon reflexes in all extremities, spasticity focalized to the knee flexors, pyramidal system involvement. In neuropsychiatric evaluation, non-word repetition and language impairment consistent with mild cognitive impairment. Findings obtained from medical history and examination suggest autosomal recessive inherited chronic progressive ataxia syndromes with cerebellar and pyramidal involvement. In addition to these, the history of juvenile cataract in the patient and additional clinical findings present in his sibling suggest cerebrotendinous xanthomatosis. When we look at the laboratory findings, the relevant parameters were found within normal limits. According to the MRI examination results, symmetrical and bilateral hyperintense lesions in T2 sequences and iso-hypointense lesions in T1 sequences were detected in both dentate nuclei. Prominent cerebellar and cerebral cortical atrophy were also present. There was no obvious pathology in ENMG. Tendon xanthomas, consanguineous parents, juvenile bilateral cataract, childhood onset chronic diarrhea, unexplained prolonged neonatal jaundice or cholestasis, ataxia and/or spastic paraparesis, signal alterations in dentate nuclei in the MRI. Vignari suspicion index score 400. Cholesterol level equals 49.48 microgram per milliliter, and homozygous mutation detected in the CYP27A1 gene. According to family history, the patient's parents were third-degree relatives. There was no neurological disease in his parents or their relatives, but the patient's 3-year younger brother had complaints of gait difficulty and imbalance starting at the age of 14. The 30-year-old brother of the patient is immobile and bedridden and has spasticity in the legs. According to the mother's statement, he has infantile onset persistent diarrhea. Gait difficulty, imbalance, and generalized tonic-clonic seizures started at the age of 14 years. Imbalance in mental functions gradually deteriorated. Epileptic seizures are controlled with valproic acid. Other findings in the sibling: xanthomas in Achilles tendons, spastic paraparesis, dysarthria, nystagmus, limb dysmetria, inability to sit on a wheelchair without support, and impaired cooperation in neuropsychiatric tests due to cognitive impairment. MRI findings were similar in both patients. On the other hand, while the ENMG of the first patient was normal, ENMG findings were detected in the sibling. In the genetic analysis, the same mutation was identified in both patients. With the present findings, chenodeoxycholic acid treatment was initiated in both patients. There was a decrease in the cholesterol levels of the patients. The imbalance in the older brother started to improve from the 3rd month. The patient who started walking with unilateral support became able to walk unaided at the end of the 1st year. Although the other sibling has multiple neurological symptoms at the time of diagnosis, there is no progression at the end of the 1st year. Epileptic seizures disappeared, and he was able to sit without support. Cerebrotendinous xanthomatosis is a disease in which neurodegeneration can be prevented, and progression can be stopped in the current clinical picture when treatment is initiated early with early diagnosis.
Okay, thank you very much. That's the end, and we'll be happy to take questions.
Thank you, Dr. Jihan. Very interesting topic, actually. It is an extremely rare disorder. I have never heard of it, actually, with CTX. So, I'm definitely going to be checking the xanthomas on our when I do ankle reflex. So
you guys are lucky. Above 15, you might see the xanthomas. For us, we're not going to see that.
I will definitely be keeping my eyes peeled out for that, especially with ataxic patients or people with progressive neurologic disturbances. I'm going to check the reflexes. Well, I do check it, but I'm going to be paying more attention to the ankles.
And take history about the infancy.
Yes. Family history is
all right,
important.
Fatima, you are with us. We will have a panel discussion now. And I see one question for you. Are there any Pompe disease expert centers in the UAE?
No, we don't have. So the data on Pompe, incidence, prevalence, and burden of disease in UAE and the Gulf countries or Middle Eastern countries is lacking. In terms of a center, no, we don't have a center. Neuromuscular specialists we have 2 in Dubai and 2 in Abu Dhabi. I think there is only 2 adults treated with late onset Pompe disease, and both of them in Dubai. So one is my recently diagnosed patient. The second one is with my colleague, Dr. Al Madani. I know there's a lot of, I don't know a lot, but there's more numbers definitely in terms of pediatrics or infantile onset.
Oh, yeah, we have a lot, yeah.
I do think, I think we're underdiagnosing for sure. luckily, my topic is much easier than both of you. So for the audience, it's simple muscle weakness, unclear cause of respiratory muscle weakness, and high CK, simple testing with the dried blood spot.
But like you said, it's really raising the awareness for those particularly treatable conditions. It's such a really sad thing if we miss, you know, a treatable condition in all these presentations, because there are many diseases which are progressive and no treatment. But you know,
you don't have to go with the like expensive genetic testing. Just do the screening with the enzyme activity level, which it is available in most like every hospital I worked at. But if not, it's also available free of charge, offered by the Sanofi Genzyme. So it's really helpful. It doesn't take very long to get the dried blood spot. It takes, I think, like 5 weeks. And then if it's positive or shows decreased activity, it reflects to the genetic testing. In UAE, we don't have a newborn screening either. I mean, if we have more data.
We have for Pompe disease.
Is a standard screening?
We have, but maybe for the adult onset, late onset, they probably have a lower, like a higher enzymatic activity that I'm not sure if it will be detected on newborn screening. But for children, we have many children diagnosed through this newborn screening and started treatment.
I was not aware that. So it is a newborn screening for all children. It's not like for floppy baby. It's part of our newborn screening.
Let me double check. I might be confusing it. Just give me a moment. Let me give you and the audience the right answer. Ahmed, maybe you can take some of your questions while I get the answer for this.
I can do that. Just also, I think one of the purposes of this rare disease conference is to raise awareness for these rare diseases. You know, I was doing some reading, and actually 300 million people in the world suffer from a rare disease. And last month, or not last month, at the beginning of March, Burj Khalifa was lit up in the colors for rare disease to spread awareness. So yes, it's rare, but they're common. And actually a lot of people in the world do have some sort of rare disease. And this is the purpose of these conferences, to raise awareness. So let me see. What needs to be done to find the undiagnosed Fabry's patients? I think you got to have a high index of suspicion, because with Fabry's disease, it is multi-systemic, multi-organ. So if you have a person with a neuropathy, unexplained, you're non-diabetic, non-alcoholic, symmetrical, ascending neuropathy that you can't explain, you'd start thinking out of the box. Like I said, you know, we're always taught when you hear hoofbeats, you think of horses, but maybe sometimes you have to think of that zebra. You know, cardiac involvement, renal involvement, early strokes is probably one of the biggest things. The cryptogenic, anybody with a young patient with strokes, and that you add renal failure or renal problems, and with a family history, we should probably be checking Fabry's disease. And next question, first line treatment for NMOSD pediatric. This was yesterday's session, but they're asking today. Yes, please. Please do.
Yeah, sure. So like I was, if you were there, I was questioning really azathioprine and mycophenolate as a treatment for NMO in particular, really, with the aquaporin 4, because these treatments take a long time to work, and you know, you might be risking having another relapse. So in children, well, usually they are adolescents. The youngest I've seen was 14 years with the NMO. We use rituximab. I know Ahmed doesn't like rituximab, but it's available. Dr. Levy was talking about the countries using azathioprine and mycophenolate because it's available and cheap. But rituximab, compared to all the other medications, is relatively cheap as well. And you know, this is the first line. Of course, some patients might relapse on it. By that stage, you probably want to consider some of the newer treatment.
No, yeah, rituximab definitely is a great drug. It works. It's very effective. I don't have a lot of pediatric NMO.
And we have a lot of experience with it in pediatrics because
Yes.
we use it to treat leukemia, and nephrotic syndrome. And so we've got a lot of experience, yeah.
What do you prefer to use, Dr. Shatila, for NMOSD?
Actually, for the NMOSD, I could, cetralizumab is one of the new IL-6 antagonists. I have used that. I do have patients on rituximab, but NMOSD as a whole diagnosis is so rare. I only have 6 patients. And then when you break that down to out of those 6 who are positive for AQP4, only 2 of them, or maybe 3. So one's on cetralizumab, one's on Imuron because Jordanian cannot afford any medications, and the 3rd patient just got lost to follow-up. And then the other patients, I tend to go with the B-cell depleters, rituximab.
So yeah, it's just interesting. People continue to use the CellCept and the Imuran, but really, if you look for FDA-approved medications, it is recently you have the complement 5 inhibitor, which non-UAE is receiving it for a neuro indication, which is also approved for myasthenia gravis. You have the IL-6 blocker, and there's another agent I forgot, 3 in the last maybe 2 to 3 years were approved for NMOSD. There's
a new one for a CD. I always can't pronounce ibenelizumab. It's I always can't. IBENELIZU-MAB. It's like a CD19. It's a precursor to CD20. So it's kind of like it's like what we're very familiar with rituximab, with ocrelizumab.
Hey, let's not forget our talks and questions about our talks.
Yes.
Okay.
Yes.
Sorry, Fatima, I've got you the answer. I'm really sorry.
Sorry about that.
Newborn screening for Pompe, no. I think I was mixing it with biotinidase deficiency. Okay.
Yeah, I think you can easily test for it, but it's not a newborn screening program in UAE yet.
Yeah, correct. We had patients diagnosed on prenatal testing because of their sibling affected. That's why they started treatment from birth, but not on newborn. Yeah.
There's an interesting question here. Thank you, Dr. Ahmed, for the great talk. We diagnosed a 42-year-old with Fabry's at SSMC. Oh, so you should probably call me then and we should talk. Do you think enzyme replacement at this age will help? I mean, I think it will, definitely, because as you saw in one of the charts or on the graph, at every age criteria, the life expectancy of your Fabry's patient is less than your general population. So if you can get access to the treatment, I think it's definitely worth starting. And call me tomorrow.
Okay, let me take 1 or 2 questions about my talk, and I think we are almost done. So can CTX cause episodic ataxia and middle cerebellar peduncle lesions on the MRI? Okay, so generally speaking, I don't think so. These are progressive disorders. So unfortunately, once we have ataxia, it's going to be there and not being episodic. Like the lesions are usually bilateral and involving the dentate nucleus. If you've got a episodic ataxia or something that comes and goes, and especially if you have a middle cerebellar peduncle, I would think of demyelination MS as something in that aspect. Of course, the other episodic ataxias, the genetically determined ones. And we have many really people being fascinating and interested in our talks, and I particularly CTX because many people didn't hear about it as well. Yeah. So thank you for raising the awareness. Yeah, great. Thank you all for being interested in our talks.
There is one question, I think, about the screening. The screening for Fabry's as well as Pompe's disease is provided free of charge by Sanofi. So if you suspect it, or if you even want to test it, there are kits of dried DPS, dried blood spot kits, 6 pieces, 6 drops of blood. You call the rep, they'll come pick it up and send it for free.
Yeah, let me mention this also, please. For the cholestanol, it's actually not as easy as DPS. It's more hard as a sample to deal with. but also TR Farm are happy to support. If you have a Minari score of more than 100, a patient you're suspecting, also if you can contact TR Farm and they will help you with the testing. Or you can refer to us or to Ahmed and we can take it from there.
And if you have questions about getting a hold of the representative from Sanofi, we can get those numbers out for you, as well as all the tests are available for CTX, for Sanofi, for Pompe's, or even Fabry's. Please, and I know Roche even does free testing for AQP4 as well, for people that cannot cover under insurance. So please reach out to us. I can connect you with the proper channels.
We didn't mention this also for yesterday. I apologize, but we had so many questions for the SMA talk that we forgot. Also, the genetic test is provided free of charge by, I think
Biogen does it.
Biogen, as well as Novartis, and Biogen mainly, I guess. And yeah, it can be done through Centogene. So if any of you guys have any suspicion of any case of the disorders we presented today or yesterday, and you need help with, referral or testing, you can contact Jared and he will forward your query to us and we can deal with it.
I can't read the question, so if anything for me, just let me know. I don't have access to the question.
Yeah, no, actually,
thanking you.
Yeah, exactly.
A lot of comments really just thanking you, Dr. Fatima, for your excellent presentation. So thank you once again.
Sorry, I've been ignoring.
No, because I think you, as a moderator, you
focusing on the questions. I don't. I'll forward them to you.
Okay.
But there wasn't much.
But with that, I think we will conclude our second day and our 2 sessions. And again, Amjad, thank you all for joining. It's always a pleasure. It's always fun raising awareness, educating our colleagues, educating ourselves as well, because I always learn a lot through these presentations. So thank you all for joining. I'd like to thank our speakers for the excellent presentations. I'd like to thank the sponsors for supporting these events, and Gerard from Focus Golf and his IT team. Thank you again. And Dr. Jihan, it's always a pleasure being your co-chair.
Thank you so much.
Thank you.
Hope to see you in person next time.
Inshallah. Thank you all. Good night. Wa ma salam, everyone.
Okay.
Ma salam. Goodbye.